Okay, so I was looking at the syllabus and I couldn't help but to notice that the first test we have 3 weeks to do, and in that 3 weeks we went over basic gerontological medicine and assessment, easy, right? Eyes, ears, also super easy and pretty uneventful. Skin, relatively not hateful, right? And we blew through all of that in a 3 week period and did really well on our exams. By the way, congratulations, guys. You got through your first exam, and there were less than a handful of people who didn't do so well. And I can promise you it's probably because of test anxiety, because I was watching everyone like a hawk, even though I was walking back and forth and you wouldn't know otherwise. Because, well, if you don't think I'm doing anything, then that's when you usually decide to move about however you want. And in doing all of that, I saw a great deal of you, many of you who didn't do as well as you wanted to, who were huffing, puffing. I saw people shaking their head no. I saw people who were putting their hands in their head. I saw people who had respiration rates in the 25 to 28 range. There were a couple of you that made eye contact with me, and I literally had to give you the mantra of "You have got to breathe, buddy." And we made that visual exchange because it needed to happen. You know who you are. I did that because I wanted to see, of those people, how many of those grades were a result of what I believe to be anticipated sticker shock or shell shock or test anxiety. And all of the people who did worse than they thought they were going to do, those are the people I saw struggling the most. So the good news is this is completely recoverable, right? Everyone knows that my average score for all of these, for the first exam for both classes, was 84. My high for both classes was a 92, so congrats on who that person is. I'm not calling nobody out. I didn't get permission, but that person is a rock star, and I'm so proud of you. And then my lowest grade was a 64, and that must have been really tough for that person. Also, not going to say anything to you, but I want you to know that I'm proud of you, and it's going to be fine. Okay? We need to follow the recipe, and we probably need to work on some techniques to breathe a little bit better. So, anybody who did less than an 80, which is only, I think, a physical handful of you, which is amazing considering how many students I have, would need to remediate with me. And remediation is not going to be super scary. I want you to see where you messed up. And I can promise you, by looking at the questions that you missed, if you would have looked down two more answers, there was an answer that kind of sounded like the one you picked, but was different by two words. And those two words meant everything to the question. So get with me because we have to remediate. Like, that's a Fortis requirement. Call me, get with me. Either we can do it on FaceTime, if you feel more comfortable that way. You guys know you basically have my life in your hands because it's cool, right? Like, I've been there and done that. I've got the t-shirt. It's a what? Size large. So do what you need to do to get a hold of me so we can do this. I don't think I have any bounds to the level of craziness I'm willing to go. So long as I'm not working my second job, which I'm not anticipated to start for another 2 weeks. So we have the time. Get with me. Let's go through it. This exam, buddy, it's a lot. We've got 260 slides per lecture, and I think week 3 has 3 lectures in it. So I'm going to be talking until I can no longer stand the sound of my voice or any other voice for that matter, for a while. And I can't tell you how long it's going to take me, but I can tell you when I'll be done because I'll be sleeping in the corner, and y'all can't get a hold of me because I'm going to put it on airplane mode. So kick back. This 2 weeks, we have to go through hematology. Yikes. We have to go through acid-base imbalances. Yikes. We have to go through hypovolemia, hypervolemia. We have to go through all of our lab values and understand what does it mean to be too low, too high. There is just so much, and we have 2 weeks to do it, and I just don't even know how that's a thing, right? And I'm sure I got 4 or 5 people going, yeah, right now, because we spent 3 weeks learning the dumb stuff, right? The eyes, the ears, gerontological assessment, all the silly things we already know. And then we get 2 weeks for the stuff that we don't know anything about. Oh boy. So I'm scared. I'm not scared for you because I can get through this. I'm just scared that I'm going to have to gently walk you into all of this because there is just a lot. So this review for exam 2 and lecture, I'm going to start off with the dumb stuff. We're going to do the basics, right? The basics, because I know there's no way in Hades that I would even remember all of this, even if I were a senior, like about to be done with this nursing student, because there's just so much. So I'm going to try to break it all down and try to explain to you all these little bits and nuggets, so that it'll be easier for you to understand for yourself. And then we will continue in lecture and class to try to go over the hot spots that I know that you really need to focus on. And the stuff that we don't need to focus on is going to be stuff we normally don't see a lot in the hospital setting, or that we're not going to see so much in the NCLEX or in the HESI. I've taken probably 25 HESIs, some for fun, quote unquote, some for, my own school. So I wouldn't say that I'm a master HESI taker, but I would say that I am a master test taker in general. I've probably taken upwards of 150 to 200 tests in my time, and I'm still taking tests still to this day, and I probably will for the rest of my life. So for that reason alone, there is a code that we can crack, and I will be teaching you this code, and I know I've said it for 2 weeks, but let me get through this review first. How I want you to do this, because there's so much, is I want you to obviously start with the review, and then go to your acid-base imbalances first, then go to your respiratory blood gases stuff, and then go to your traditional hematology if you can. Do it in that order, and then we'll kind of go from there. I am throwing a lot at you. I don't have a choice about throwing a lot at you. So take a deep breath. We can do this. We can get through this. It's going to be okay. I'm proud of you guys. Let's make it great. And don't forget to come see me if you need to remediate, okay? Because we got to get that done before we can move forward. Oh, and really quick, all of the people that had the questions about the next gen questions being kind of messed up, don't forget to get a hold of me in class so that we can deal with it, because I need to get that handled this week. I have the ability to fix those problems if you remediate with me. I will absolutely give you full credit for those. So the people that got 10s out of 20s, don't flip out about it. I'm not going to let you fail. I'm going to do whatever I can to give you every bit of points that we can get, right? I just want to know that you comprehend what's going on and why the answer that you chose was not the right answer. And then we can move forward, and that's it, okay? People fall all the time. It's how you get yourself back up that matters, all right? So let's get started in this crazy exam that is hematology, acid-base balances, and respiratory issues galore. Okay, so starting it all off. I know as a nurse, I didn't understand my my CBCs, my BMPs, my BNPs, my CMP. I didn't know any of that stuff. I knew potassium and I knew white blood cells, right? And I knew magnesium, kind of. Calcium, forget it, right? Unless it was parathyroid related. So I just completely was oblivious to all lab values as a nurse, because I was just trying to take care of, how do I know if someone's got cancer? How do I know if someone's about to die of an acute MI, right? Like, who's worried about those things other than troponins? And then later on, I had to backtrack while I was studying for the NCLEX, and I had to teach myself these things. And if you've ever taught yourself how to study material that you are not meant to teach yourself because it is some wackadoo concepts, you will get physical nosebleeds, and it's not fun. And I'm not saying that from experience, although I am. So let me walk you through gently what it looks like to have all of these letters and no vowels, so that we can kind of get a basic concept of how all of these pieces and parts work. I'm going to break them apart like CBC. I'm going to break down everything that's on the CBC. I'm going to break down what the values are on the CBC. This is what I call your Bible to acid-base balances. It's going to be a lot of slides. It's going to get a little daunting. I want you to pay attention to it. I know that you guys, some of you hang on to my every word, and I just think that's amazing because it makes life really easy when it comes test time. But it's also going to make life really easy when it comes to a person's in front of you and they're going to live and die by the things that you visualize in your results review of the EPIC, right? And if you don't know what that means all of your labs sit there and they either are red, which means bad, or they're black, which means okay. So you need to know when to get a physician and when to not get a physician. Prime example, I called a cardiologist as a brand new nurse. This is so embarrassing. I don't even want to tell you guys this, but I don't even care. So as a new nurse, I called a cardiologist because I had a high chloride level, right? It was like, oh my God, this is out of range. And I called him, and I'm not going to say who he is, although he became my godfather later in life, renowned world cardiologist. And he goes, why are you calling me for a chloride? And then hangs up with me because the chloride doesn't really matter in the grand scheme of things, right? If you know me outside of the teaching environment and you've worked with me in the past, there are a couple of you that have because you know I'm a traveler as well. Or you've seen me in clinical settings as a traveler, you will know that when people say something about a BUN, I will always say, nobody cares about a BUN. And there's a reason for it because BUN, while it is a good relative way of determining something, you need something else besides a BUN. A BUN is nothing more than saying, hey, I've got chest pain. All right, let me do an EKG. An EKG, which is a monitor, is not going to let us know what's really going on with the patient. You need a trope, right? So, yeah, EKG is a good start. Yeah, BUN's a good start. But nobody cares about BUN, ever, in a real world setting because we look at things that are more important like a creatinine, right? Because that's a definitive end-all be-all. So, like I said, kick back, relax. We're going to start it real slow. So, CBC, super easy, complete blood count, measures the 5 key components, right? So we're talking red blood cells, white blood cells, hemoglobin, hematocrit, and platelets, all right? This is all blood stuff, which is why it says a complete blood count. I know, it's right there in front of your face, but I promise you, it didn't even dawn on me. Because when you're a stressed out nursing student, the dumb stuff, which is, hey, complete blood count means, hey, guess what? We're talking about blood here. The dumb stuff you don't even think about because you're just so overwhelmed. And I get that. And everyone knows that I'm a fairly intelligent individual, kind of. I'd like to think so. I hope I'm not boasting. I'm a little smart. And that being said, if I'm able to make that kind of mistake, then somebody else is probably doing the same. So this is going to be a measurement of what our blood is doing. So we need to know red blood cells because those are the ones that carry the oxygen, right? Think of a lazy river. Think of a lazy river at, I don't know, Six Flags, Wild Adventures. What do you guys call it? Oh, this is the North. Yes, theme park. That, whatever that is. Let me know what it is. I'm sure I've been, yeah, I've definitely been there. I just can't remember the name of it. Anyways, lazy river. All right. So the donut that you sit your little caboose in, right, while you're drinking your Coca-Colas, because nobody would do anything worse than that, that would be the red blood cell. And you sitting in said donut would be the oxygen binding capacity. Okay, this is how I want you to look at blood and the blood flow. And this is going to come back to haunt us when we start talking about anemias, but we'll get there in a second. So just know your red blood cell, if you're looking and you're cruising down the lazy river with all your buddies, then those are the basic components in the building blocks of the structure of the cell. White blood cells, they are fighters, buddy. They are my awesome people. So when I think of white blood cells, a good way to remember it is, so Cobra Kai is a show that's kind of popular. It used to be called Karate Kid because that's, my generation, which just aged me. Get over yourself. It's cool. I make 40 look good. So with those guys, I always think of Daniel LaRusso. He wears what color gi? He wears a white gi. And what does he do? He fights, buddy. So that's how I remembered white blood cells. I know that sounds stupid. If you find a better way to do it, by all means, please share it with the classroom because whatever is going to work for you might work for somebody else. So white blood cells, they're the fighters. They fight the infection, and when white blood cells are elevated, they will show an infection. Sometimes there will be anticipated white blood cell increase, and that would be for people who are post-surgical. You will notice really quick that whenever you have a stent place it, or whenever you have any type of service that is surgical requirement, even if it's like a bedside procedure like I don't know, lumbar puncture or IND, those are always going to increase your white cell count the next morning, and I'll tell you why. So we'll get into that in a little bit. Hemoglobin. Those are your oxygen carrying proteins in the red blood cells. Now go back to the lazy river. Kings Island. Ha! I knew I was going to get it. Kings Island. Yes! Score. +2 for Molly. All right. Sorry about that. Squirrel. So with the lazy river, the red blood cell, again, is that donut, and you, who was drinking a Coca-Cola because you wouldn't drink anything else, you would be the hemoglobin. So you are the oxygen binding protein that is in the red blood cell. Your hematocrit is the proportion of red blood cells to the fluid component, plasma, or blood. And all it means is just like how concentrated, right? How much of that is the red blood cell proponent. And that could be a good thing or that could be a terrible thing. And we'll talk about hemochromatosis in a little bit. That's one of you guys calling me. So really quick, platelets are going to deal with your blood clotting. Low is not great. High, it really doesn't matter, but it can be a problem, obviously, if we're talking about things that are too clotty. So we'll get into that here in a second. And then what is the CBC used for? It can be an identifier for infections, anemias, autoimmune disorders. Hang on, let me get this. Okay, it went away. So it can be used to identify infections, anemias, autoimmune disorders, bone marrow disorders, thrombocytopenia, erythrocytosis, cancers, leukemias, and a partridge in a pear tree. So, by the way, these cats in the background, I thought this would be great because this is kind of how I feel like your face is doing right now. I don't blame you. It's going to be okay. Everything's going to be great because we're going to do this together. So, CBC. Here's your 5 parts. Know that these are your 5 parts, and know that a CBC isn't going to have anything more or less than what's right here. And then we'll get into what those levels mean and why. Okay, so normal CBC levels. They're all listed here. White blood cells, 4,500 to 10,000. Sometimes that varies a little bit. Sometimes hospitals are like, 11,000 is fine, or 4,000 is fine. But if we get too low or too high, we start running into some kind of hairy territory. So too low of white blood cells, that could be from multiple myeloma, aplastic anemia, HIV, chemotherapy. When we get to the 2,000 mark is when we start talking about neutropenic precautions. Neutropenic precautions are for people who most of the time are on chemotherapy, and they have these really low white blood cell counts. We have these really low platelet counts, and we get into a territory where we're so immunocompromised that we could actually cause more damage than good if we expose ourselves to them. So we treat neutropenic precautions as if we would treat some type of droplet situation, because we don't want to get them sick, because I might be a carrier of something, especially, never having COVID myself, which is ironic, right? Never having COVID and being a COVID nurse who really was in New York when it all went down. I was there for the first 4 weeks before I came back to my hometown and started opening COVID units nationwide. So I've never gotten it myself, but I could easily be a carrier. So that would be a big problem to give that to somebody who is on chemotherapy. That would be curtains for them, right? So that would be a terrible idea. We get into the too high territory, and we're dealing with obviously infection, but it also could be like inflammation. It could be surgery issues. Like I said earlier, I think whenever you have surgery, it's just expected that 4 a.m. lab, the next lab that you're going to do, is going to be high. So we don't get too ate up about it if we see, white blood cell count before surgery is maybe 11,000 because maybe they've got an appendicitis, right? And then after they're done with the surgery, even though we give them Ancef as an antibiotic in the middle of surgery, and then we give them every 8 hours on top of it, I've seen these white blood cell counts go like 20 overnight. And I remember being a new nurse and kind of freaking out, and the doctor going, yeah, to be expected, cool, leave it be, and then they hung up, right? So just keep that in mind if you can. Remember though, we have to make sure that we don't get too high or too low into the territory. If we do, we obviously need to have them on some type of plan of action to get those numbers better, because we obviously don't want to put them in a bad position. Hemoglobin 12 to 18. This number also fluctuates a lot. So my two babes that have your dialysis background, you know that hemoglobin at 12 is never going to happen in your world. And if it does, tell me about it, because I'd love to hear. I rarely hear patients who are on dialysis because the long story short is they can't produce enough erythropoietin to keep things going, and I'll explain that later when we get into the craziness that is the hematology portion of this. So when you have a lower hemoglobin, there's some variance. I can have a 10 hemoglobin coming in the gate. I'm not touching it because that might be my regular number. Now here's where it gets hairy, because hemoglobins, sometimes we let hemoglobins go down to 6. Sometimes we let hemoglobins go down to 7. Sometimes for transfusion at 8. So how do you figure out what the answer is? Okay, here's the answer. The answer is there is no answer, because every doc is different. Like I said, with these dialysis patients, sometimes we won't infuse them until they get to 6, and here's why. What are we taking off of dialysis patients? Fluid, right? Because that's what causes all the problems. You know, they retain so much, their potassium is through the roof. Lactulose, most of the time people are non-compliant, right? So we have to use traditional methods of dialyzing a patient to get them better. So long story short is if I have a patient that's 7 and they just got dialyzed, cool, because I'm expecting that, because we're pulling stuff off of them, and they're not gonna, like I said, they can't create new cells or new red blood cells as fast as we can, and they can't have that oxygen binding capacity as fast as we can, because neogenesis isn't something that happens when you have a failed system, right? So don't get too stressed out about that little bit right there. Just know hemoglobin, it goes from 12 to 18. When you have hemoglobin issues, we have anemia issues, we could have GI bleeds, we can have cancer, we can have cirrhosis of the liver, we could be on dialysis, we can have hemophilia with an injury, we can have end-stage, kidney disease like we just talked about at the end. If we have too high of hemoglobin, because that's actually a thing, believe it or not, I was married to a colonel for 10 years, way back when. And he had a sister whose husband had hemochromatosis, so he would actually have to get bloodletted, which is kind of crazy and kind of wild, because he had far too much in his system, which would also cause other issues. It causes, let's see, too high, it could be from hypoxia. And I know everyone's like, wait a minute, hypoxia and too much hemoglobin, wouldn't that not make any sense? No, it wouldn't. They have hypoxic reasons because of COPD, because of a lung dysfunction, right? Where they are producing a ridiculous amount of cells, right? So they're trying to compensate by making all these red blood cells so that they can take a good breath. And the tip off is we have all of this oxygen. Now, if I'm a COPD, or do I want all of this oxygen? No. Why? Because I can't pull off what? Carbon dioxide. So this is why we have people in the COPD exacerbation. This is why their blood levels are all crazy as far as their gases are concerned. And this is why we have to stick them on a BiPAP machine so that we can help them get all of that off. So that is why you see something like hypoxia, even though your hemoglobin is the oxygen binding capacity, which if you can't breathe very well, one would think that it would be the opposite effect. But no, in this case, if you have a lung condition, you're creating so much oxygen and you can't push it out that this is where the problem exists, okay? Lung, kidney, or liver disease as well, okay? Hematocrit is basically the same, right? So when you're dealing with hematocrit, when we have too low of hematocrit, again, anemias, vitamin, mineral deficiency, leukemias, lymphomas, all of the things. Too high, polycythemia, polycythemia vera specifically, and then again, lung and heart disease. Platelets, again, this number kind of fluctuates. It kind of bends and weaves as it wants to. It goes from 150 to 450. Now, here's the thing. when we're talking about platelets, sometimes we create platelets to be on the low side, specifically when we're dealing with people on heparin. Now, if you've never had a patient on heparin, or you're not a tech and you haven't had an opportunity, heparin is an IV piggyback that we have whenever we have a patient who is having a myocardial infarct, who has a DVT, who has, let's see, what's another one, who has a thrombus, that is migrating, anything that is super scary like that, that's going to cause someone to die. We want that blood and that clot not necessarily to bust, because that is not a clot buster. It is a clot, reducer, if you will. Because if I'm on heparin, the clot that I have, it's still there. That's not going to change anything, but it will prevent other clots from forming. So heparin is kind of yellowy looking. It comes in an IV bag that's like 250 milliliters usually. We usually give them a very, very small drip rate. Sometimes it starts off with like 18. I've never really seen it go over like 26 GTTs per the hour. So sometimes we have to give a bolus for the heparin. There's a lot going on with heparin. Just know that sometimes we purposefully bring down those platelet levels so that we can prevent a person who has too thick a blood. There are certain diseases, factor 5, I believe, has the thrombo producing disorder, whereas factor 8, which is like the opposite, which is hemophilia, which is what I have, or von Willebrand, is going to produce the opposite reflex, where we do have a tendency to bleed out a lot easier, right? So keep those in mind. Too low, you could be on heparin, you can have hep C, HIV, heavy alcohol consumption. That's also one that we see very often. Cancer, some anemias, and it is called traditionally thrombocytopenia when you get stuck in this situation. And you usually have what's called thrombocytopenia purpura. You bruise really easy. You have like these weird petechiae, spots of purple kind of everywhere. It's kind of wicked looking for sure. And then if you have too high of platelets, that's called thrombocythemia, right, which is an autoimmune disease inducing situation. It also could be an iron deficiency problem, because if we don't have enough of those iron binding complexes within the red blood cell, what do? Well, we just tell the red blood cells to make more, right? So if we make more cells to try to do that, we're going to have, a higher platelet count, but not necessarily enough iron binding complexes. So that's why we have that problem. And then also with trauma, because again, we're sending the system out to clot everything that is currently bleeding out. And as a result of that, you're going to have a higher platelet count as the body naturally tries to save you. So keep those things in mind and make sure that you understand those levels. The reason I need for you to understand these levels is because you will see questions on the NCLEX, on the HESI, and on your exam that are going to say things like, which of these are going to be of a concern to the nurse, right? And it's going to list all of these levels. And you were looking for the abnormal level. So make sure you know these numbers, because if you don't know the other answers by default, that is going to be your answer, because that is the one that is off, right? So I cannot stress to you enough. I missed a lot of opportunities to make a much better grade than I did because I didn't know something as silly as what my hematocrit level is when they're asking a question, or what, my PTT was, which I'm not going to have you freak out over right this second, or, knowing that a white blood cell count of 8,000 is fine. But obviously, like a platelet count of 75,000 or 78,000 or 80,000 or 90,000, all of those big, big fat problems and need to be addressed immediately. So keep those things in mind. Okay, so this slide looks super intimidating, and I'm totally with you, but it is not that big of a deal. So white blood cells, basically when you do a white cell count, it breaks down what percentage of neutrophils you have, what percentage of eosinophils, basophils, lymphocytes, and monocytes you have. And all of these things mean different things, but the one we look at the most is normally our white cell count, and then we look at our neutrophils, because the most important infection fighting white blood cell is the neutrophil, right? So the number the doctors look at is called your absolute neutrophil count, and a healthy person has an absolute neutrophil count between 2,500 and 6,000. Now, it looks right there. It says neutrophils normal, 45 to 73%. What's going on? Now here's how it goes. The absolute neutrophil count is found by multiplying the white blood cell count by the percentage of neutrophils in the blood. So, for instance, if the white blood cell is like 8,000 and 50% of the white blood cells are neutrophils, then the absolute neutrophil count, which is 8,000 times 0.50, would be 4,000. Now, did I confuse you? Oh, for sure. I know I just confused you. Here's what I need for you to know. I don't care about the percentage of neutrophils. I don't care about you throwing this calculation together, because the bottom line is this number is already going to be in your results review in any charting system that you have whenever you get labs drawn. Here's what I do need for you to know. I need for you to know that when the absolute neutrophil count drops below 1,000, it's called neutropenia. Now, in some hospitals, just out of pure precaution, like Ohio Health, for instance, they call neutropenic precaution 2,000, because you don't want to play games with these guys, because they are super duper sick and they are super duper easy at catching virulent issues, right? So if I'm a carrier of something, they're going to get it in that position. So I mean, like, no flowers, no allergens, everyone's basically dressed as droplet precaution. I am kicking family out of there if I see them throw up their mask when I open a door, because that means I've kept it down and that means I'm ready to go ahead and kick some tail. That type of a deal. So I don't want you to worry about the percentage. I'm not going to ask you to calculate the percentage. That's psychotic. Med school docs don't even do that. I'm not going to do that to you. That's nuts. I need for you to understand that when we look at these percentages, a higher percentage of neutrophils usually is an indicator for a bacterial infection. And an absolute neutrophil count that is below 1,000 is what we consider to be a neutropenic issue. Now, your doctor is going to watch that closely, because when you get below 500 or at 500 and you start spiking even a little bit of a temperature, I mean, you could have a temperature of like 100.9. Normally with 100.9, I'm giving you a Tylenol. I'm coming back to check you within an hour, and I am not too worried about it, because 100.9, it's barely even a thing, right? However, if you have a neutrophil count of 500 and you've got a temperature of 100.1, 100 point anything, 100.9, I am freaking out, because it is going to go really bad really quick, because these guys go from cool as a cucumber and life is peachy to really, really bad in less than 6 hours. So you need to watch out for these people and know that that's the most important. I don't care about blood pressure being low. Like if it's, I don't know, if it's 95 systolic, whoopity-doo, right? They're on chemotherapy. I would expect that to be a finding. If their heart rate's, I don't know, 101, I don't care. I would expect that to be a finding, because we're in sympathetic nervous system response and I am on chemo. So you're going to be nauseous and vomity. And when you're nauseous and vomity, your heart rate's up, right? My respirators are going to be up too. If it's 22, all right, that's the higher capacity of my levels that we're cool with. So I don't care about that either. It's literally that silly temperature of 100, point whatever that looks like, is an indicator that we're getting sick, and we're getting sick quick. There you go. So we need to do something. If we have an absolute neutrophil count, once it hits 1,000, we're raising an eyebrow and we're like, oh man. And then once we hit like 500 or below, I mean, that's when it really hits the fan with these guys, because they can get, like I said, they can get really sick in just a matter of hours. They're that fragile. So please remember that part if you don't remember anything else in the whole wide world. All right, next slide. So I know we talk about hemoglobin a lot, and I know we talk about hematocrit a lot, and I know we talk about platelet counts a lot. So I want to go ahead and drive it home one more time, right? Because it's that important that we understand this. And it's also fair game on your exam, so just keep that in mind. So when we're dealing with hemoglobin levels, and we have these dicey hemoglobin levels, first off, if you're going to see them, you're not going to see them like a hemoglobin level of 11, right? It's usually going to be a hemoglobin level of like 10 or like 8. When you're talking about your NCLEX or your HESI or anything like that. But you need to know whatever the standard textbook numbers are. I believe that these are the correct standard textbook numbers. If you're said otherwise, go with whatever your textbook says. Males versus females, obviously males have, more capacity to produce more cells because they have more binding factors, yada, 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 more muscle mass, blah, 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 words. And then females have a little bit less. But the fact of the matter is if I have a patient who has a hemoglobin of 12, isn't feeling well, comes into my hospital, comes back, and then has a hemoglobin of 10, I'm seriously thinking about transfusing that, because if I've lost 2 grams of blood overnight, something isn't right. We've got to bleed somewhere, okay? So even though my number might sound fine, I need for you to watch out for these numbers, and I need you to also, if you have adults that are within the, cycling range, if they're female, you need to see if they're on their cycle. Sometimes people don't know that they have hemophilia, and sometimes it could be such low-grade hemophilia, like a von Willebrand, that they go on about life getting sick and being almost transfusible, but not quite transfusible. And then when they have kids, their kids end up passing out for various reasons during their cycling time as they, age and get into maturity. And that's when they finally figure out these issues. So I need for you to keep your eyes and ears open, specifically your eyeballs, because if we see these numbers overnight drop in a gram, drop in 2 grams, we're missing something along the way. So you need to ask these people, hey, lady who's 46, don't do it that way. That's crazy. Are you still having a cycle, right? Because sometimes 40-year-olds don't know that they have this issue, because a lot of people honestly don't like going to the doctor. So sometimes they just live with it their whole life, completely oblivious. I know it sounds nuts, but I'll get into that in just a second, and then you'll understand how that's a thing. Hematocrit. Whenever your hematocrit is higher than it's supposed to be, please understand that these guys have basically thick, sludgy blood. You can tell people who have high hematocrit levels because you will go to give them an IV, you will stick the IV, you will clear your chamber full of blood, and then all of a sudden, you got nothing. And you're like, wait, what's happening? And then you maneuver around, you try to flush it, it doesn't flush. You're like, wait, I know I got that IV. I know I got it. And then when you go to remove the IV, you'll realize that there was a clot that was formed at the tip of that catheter. And that's when you need to freak out, because those guys need to be heparinized. And I've run into that. Let's see, I've been doing this, a decade now? Yeah. I think I probably ran into about 15 instances. And when I see it, I calmly get up, as calmly as I can be, because you guys know there could be a hornet's nest in my lap, and I'll just sit there and chill for a second, like, oh man, that's inconvenient, right? Which is how you need to act, because these guys are in trouble, big time, trouble, okay? So hemochromatosis, I keep going back to hemochromatosis because A, it sounds fun to say, hemochromatosis, and B, because these are the main guys that have this problem. These guys have strokes, these guys have heart attacks very easily. It could cause them serious injury and immediate death if it isn't handled appropriately, and we don't get them thinned out, and we don't bloodlet them like they're supposed to be bloodlet. I know it sounds crazy. I know we haven't done that since like the 1800s, but man, I tell you, it's a thing for sure. Man, woman, non-binary, I swear it's a thing. So keep an eye on that. Obviously, low hematocrit is going to be in anemias, or after acute heavy bleeding from like a motor vehicle accident or a trauma injury, so you need to keep an eye out for those as well. And just because they're just barely off of the range does not, I repeat, does not mean that it isn't something that we need to be concerned about, because I don't know why we always play this classic game of if it's 8 or below, you need to transfuse. And while that is technically accurate, a lot of times no one cares about 8 in a hospital setting. So for the purposes of the perfect world, if the answer is their hemoglobin's 8, what should we do? We're going to call the doctor and see if we need to transfuse, right? That's the technical answer. But in the real world where people live and grow and, exist, they're not necessarily going to care about 8, but what they will tell you as a physician, and I tell my nurses this all the time, hey, listen, when we get past blank number, that's when you need to give me a call, because that's when we need to worry, because again, some of these guys are dialyzed and they just have lower hemoglobins that we can play around with, right? Sometimes these people with GI bleeds, they will have a normal range number in the beginning, when they first come in and complain of incredible pain, and we roll our eyes at these people. But I'm sorry, if someone's alert and oriented and with it, and I'm talking to their wife, and their wife's like, he hates going to the hospital, if I hear that and he's in my hospital complaining of abdominal pain and saying that something's going on with his poop, I'm thinking to myself, oh boy, we have a problem. I don't care what that number says, because all it's going to take is time, and then we're going to be where we don't want to be. So just keep those things in mind, guys. All right, so we know about CBC now, which is excellent. So now we're going to move on to metabolic panels, and you will hear a doctor say, order me a metabolic panel. And the first thing you're going to do is Google it because you're going to be like, what's a metabolic panel? And while some of you are probably diligent students and know the answer to this, I will give you a 100% wholehearted answer that I, as a brand new nursing student, had no clue what a metabolic panel meant. I didn't know probably the first 3 years as a nurse, right? Because docs do that. That's not my deal. At least that was the mentality I had. And boy, was that ever changing quick. Because by year 3, I was a pro ready to go. You know what I mean? So BMP and a CMP are going to be your metabolic panels. And again, what are we doing? We're evaluating your body's metabolism, hence metabolic panel. So basic metabolic panel and then complete metabolic panel, a little bit different. I'm going to focus heavy on the BMP versus the CMP because when we get into liver enzymes and we get into liver cirrhosis and all that jazz, we'll get into CMP. Right now, I want you to know BMP because the next slide, there's going to be a lot of numbers. There's going to be a lot of stuff, and I don't want you to freak out because there's nothing to freak out about. We're going to go through them one by one, and then we'll be good. So let's go. Okay, so now we've got the dream team of lab values minus the BUN because I'm notorious for not caring about BUN because honestly BUN only gives us a small picture and it is honestly not an indicator for a full diagnostic finding. There, I said it. I'm sure I'm going to have 5,000 people come at me about that. I don't care. Come at me with your best evidence-based practice and I'll come at you with mine. And by default, I'm probably going to win this one because bun is ridiculous. It's important and, it's good if you put some caramel drizzle on top of it and, eat it when it's fresh and hot. But other than that, BUN or what people call bun, which isn't a thing, is the most ridiculous thing ever. Yes, it can technically indicate if someone's dehydrating. However, my bigger player in the game is creatinine, right? So like, would you bring, would you bring a bottle of soda to a Christmas event, or would you bring, a cake, right? You bring the daggum cake because that feels like you care more, right? That's what creatinine does. It cares more than BUN. There, I'm done talking about BUN. I'm sorry. If we get a question with BUN as an answer, oh man, I'm just not going to even let that happen because that's ridiculous. So BUN, it is an indicator for dehydration, although not a full diagnostic. Creatinine you're going to see often. We are very careful to raise creatinine because we have dialyzed patients who have creatinines of 8 and 9, which is insane. We have patients who we have to give IV contrast to who are on metformin, and both of those things are going to be a kicker to your creatinine. I don't want to throw somebody's kidneys in a flux. So let's talk about kidneys. So when COVID was the thing, and it still is, but when COVID was a deathly thing, and I'm up in New York hating my life, and I'm here and there opening all these COVID units and COVID ICU units throughout the state of Ohio after the New York incident, I hated how bad we killed our kidneys because our kidneys, I have learned, are probably more important, oh man, I'm really going to regret this, dare I say, than the cardiac system because the kidney, once those kidneys are gone, you might as well just give up the rest, right? So while I agree, your heart is incredibly important, right? Incredibly important, and you can live without your kidneys, I get it. Your kidneys dictate what's going to happen to that heart. I look at this like a bad relationship, right? There's one good person in a bad relationship, and there's one that just ruins the relationship. It could be a friendship, it could be a marriage, I don't care what you call it. Look at it however you want to. But in a relationship, when there is a bad situation that happens, you must always see this one person that every time the happy person, aka the heart's like, hi, how you doing? Let's go hang out with each other. Let's go do things together. The other one's all salty, which is funny because his kidneys, and is like, yeah, well, I remember last week when you said that, and then it took us 45 minutes to get out the door. And what does it do? It makes the heart feel crappy, right? So then what does the heart do? It kind of dies on the inside a little bit, right? Like, I'm using metaphors, but this is also physically what happens, to be fair. So make sure that you're watching that creatinine. That creatinine cannot be off. If it's over 1.2, we need to go ahead and give them a little bit of fluid replacement if they can handle it. Sometimes if we have a CHF patient that we have to give contrast to for a heart stent placement, we will put them in the hospital a day early just to give them what we call gentle fluids, which is about 50 milliliters an hour, which the heart can take even in a state of CHF. If it is a regular person like myself that doesn't have any heart conditions, they will go ahead and fly through 150 to 200 milliliters an hour, and they'll do that continuous until my kidney function gets better, and they'll usually do a redraw in 12 hours. That's pretty normal. Glucose we don't really need to get into too much. Chloride, don't call a doc about a chloride that's elevated because they don't care. Don't do it because you're going to get hung up on like I did. And they just might be one of the most powerful people that, the nation has birthed. And you'll be super embarrassed. And even after knowing that person for nearly a decade, they will always remind you that you called them about a high chloride. So there's that. Potassium. Potassium you will always find on an NCLEX. You'll find it on, I guarantee you're going to find it on your HESI test. You're always going to find it on a regular test. It is what it is, right? Because potassium is such a big deal. So too low of potassium, we have big problems. What causes it? Well, diuretics cause it, obviously. Volume deficit issues from increased, nausea, vomiting, diarrhea will be a problem. Medications, lactulose, all those things will also decrease that potassium level, which is why we give it to dialysis patients in hopes that we can, get them to drink enough to do what needs done. Although most of the time they're non-compliant and don't get into it, but I'm not going to do that. What I'm trying to get at is when you're dealing with potassium, know these numbers. So this one says 3.7 to 5.2. I was taught 3.5 to 5.3. Whatever your book says, I more than definitely promise you that if you have an answer that has the word potassium in it and it is out of range, I don't even care if it's off by barely. I promise you that is going to be your answer 100% of the time, because it's never going to be in a select all that apply. It's always going to be a super complicated issue. It's going to be like Bobby Sue and Mary Jo have, serum lab levels for a client that's prescribed, I don't know, Lasix, hydrochlorothiazide, something of that nature, and it's going to go, what are the findings of potassium levels, and you're going to see potassium like 2.2, or potassium like 3.2, or potassium like 5.8, or 5.5. Like, it's always going to be either higher or lower, and that's going to be your jam. So 100% of the time, know your potassium if you know no other level in the whole world, because it's going to come back to bite you. Now, the next one you need to know for sure is your sodium level, because you're going to see that just as much. Your creatinine, your potassium, your sodium, your calcium, those always come back to haunt you in these big exams. And specific to sodium, you're going to see things like, is this person have a decreased serum sodium level based on, their symptoms, right? So a decreased serum sodium level, which we're going to get into in a second, is going to cause you to have a bounding pulse, and you're going to be confused because you're hypervolemic, which means you have too much fluid, which is why you have your bounding pulse, right? Which is why you're confused, because you basically have a waterhead. So that's how I want you to look at these things. And the most important part is to know your levels and know what hypo and hyper mean for the patient, specific to creatinine, specific to potassium, sodium, and calcium 100% of the time. If you want to go ahead and spend time and waste your energy learning about BUN and what, low and high means, by all means, please. I have never seen a test where BUN was the answer. I'm sure there's one out there and there's one question, and I'm sure that by saying this, we're probably going to get that in a HESI, right? So just for the sake of that and for the sake of knowing that you aren't going to look at me yelling about BUN and how I messed you up, just know the lab values and know what up and down means. But other than that, move on with your life because it's not going to be a thing. Calcium's also a big deal. Sometimes you're going to have really gnarly high calcium levels. If someone had, parathyroid surgery, they're going to have a calcium deficiency, right? Because the thing that created the calcium is no longer there. And I know I just said high calcium. I didn't mean that. What I do mean for high calcium is something like multiple myeloma, right? So why would that cause anything to go up as far as calcium is concerned? Well, multiple myeloma is, bone issues. And what happens is those bones, as the marrow starts to, eat away at itself and the bone deteriorates, it drops off, its little pieces in pobs and cogs. So it's like when you eat a peanut butter and jelly sandwich without a napkin. You're going to get crumbs everywhere, right? Same deal, only the deposits are calcium deposits, so you're going to be hyperkalemic, right? So you need to just watch out for those things and make sure that you understand what that looks like and make sure that you understand what your levels are, because it's just as important, especially when you're dealing with problems like tetany, to check those levels. So keep that in mind. Okay, so I felt bad about making fun of Bun, which isn't a thing, by the way, which is why I call it Bun, to be sarcastic, because I still want to thump it in the forehead and maybe knock its books out of its hand while it's walking down the road, because let's face it, the glasses that they're wearing, it's got tape on the middle, right? So it's just fair. So let me just go ahead and say my piece and make BUN feel a little bit better about being called Bun and, buns and all the other puns that we got with the bun. So it may be a reflection of your glomerular filtration rate. And it's important in its renal function. I will give you that to my darling dears who are my dialysis folks. I will give you that for sure. I would panic if it's over 100. I'll give you that, because we're talking about catabolism at that point. Not cannibalism, that's nice try. Catabolism. So, okay, fine, I'll give you that. If it's increased and you're pre-renal, these are the issues that you can have. You guys are more than welcome to read. If you're in a full-on acute renal failure, it could be as a result of the nephrotoxic drugs. It could be from glomerular nephritis, chronic renal failure. Analgesic abuse is a huge one. Post-renal is normally an obstruction. Okay, cool. It's an indicator, but it is not an absolute. So how about I say BUN, its hair looks really pretty and it's got a good personality. How about that? Is that fair? I feel like that's fair. So if it's decreased, it could be an indicator for malnutrition, profound liver disease, fluid overload because it's dilutional. However, it is not really clinically significant, which is why I say no one cares about it. You have to look at it in correlation with your serum creatinine, because that's going to be your better indicator. And if someone wants to argue that point to me, because I will argue BUN into the ground, if someone can argue a point that is solid, that is a solid point, give it to me. Give it to me. And you know what? It's going to be a fun argument, and I'm gonna enjoy everything you have to say, because I really, really want to know why we even care about that, to be fair, because it's only a clinical indicator, and it's not something that is super specific. However, we always teach people BUN, and I just don't get it. Okay, I'm done. I said my piece. BUN, it's got a pretty personality. It's such a good personality, and it cooks well, and it cleans up real nice, and it takes care of my cats. And that's BUN. So there you go. All right, going back to creatinine. Creatinine's a big deal. It's going to show the toxicity level of those kidneys and how toxic everything is in there, which is a huge deal. That's also going to be an indicator of what my glomerular filtration rate is going to be doing. 99.9% of the time. There are certain instances where that is not a thing. but for the most part, one follows the other. So normally we're going to have 0.7 to 1.5. Again, do whatever your book says. These are the numbers I have. Don't worry about the kid numbers. I just threw those in there for good measure, just so you know. It is constant in patients with normal kidney function, which is fine. It's supposed to be, right? So when we have an increase in serum creatinine, we have worsening renal function, obviously. These are the reasons that we would have this. Sometimes lithium will throw it off. Exercise. Okay, so let's go ahead and have my creatinine discussion. So I had a 20-year-old who was a bodybuilder. He was the coolest guy I have ever met. More than likely. I might, yep, okay, I'm giving it to him. He was the coolest guy I've ever met, right? Like super cool as a cucumber. Nothing ever bothered him. He reminded me of a dude in like Colorado or Utah that's just like, whatever, man. Like that was just kind of how he was. He was 6'2", and I mean, he was cut. He had less than 10% body fat, and he took it serious, right? So he was going to get ready for, his day. He had a competition. He was taking Explode to get all beefed up. He was going and tanning himself and shaving his whole body, doing the whole nine that bodybuilders do, which is kind of funny to me, but I certainly respect it. And he started feeling terrible. He came into the hospital. He was in basically acute kidney failure and was almost in full failure. To the point where we had to put him on a temporary dialysis HD cath and dialyze this guy. No, he did not have COVID, although that was a good thought because, quite honestly, most people that have COVID blew their kidneys while they were going through the dying process. But that's another discussion. That's not this time. This guy was taking this Explode 3 or 4 times a day, which is like a pre-workout drink. Oh, God. I feel like at least 10 of you guys just got high alerted in your brain. And because it contains creatine, he blew his kidneys taking it, for sure. So we had to temporarily dialyze this guy for, God, it felt like a month for sure. And then we managed to get his kidneys back. They were worse for wear, but they were still functional, and that was exciting. So make sure that you understand that whenever we start taking these drinks, we really, really need to watch what's in them, and we really don't need to abuse them and do what it says to not do, which is take it more than you're supposed to. I believe pre-workouts you can only take twice a day, and he was eating the powder. He told me like he would eat a tablespoon every couple of hours, and that's how he got ready for, his big deal. So I guess football players, they carb load. And he loaded and exploded his kidneys nearly. So that's how serious creatinine is. We need to make sure that we understand the ratios down here. I want you to know that a normal ration is 10 to 1. 20 to 1 is going to cause us dysfunction. And then it's going to cause renal damage. Even with a 20 to 1 ration, it may be normal if both your BUN, who has a great personality, and serum creatinine are within the normal limits. Some people just carry a higher ratio, and that's okay. No big deal. So of all the things I need for you to pay attention to, know your limits, know what a bad serum creatinine looks like, and know if it's too high. Let's see, you're gonna give fluids. If it's a CHF patient, you're gonna give gentle fluids, and you're gonna knock off the metformin, and you're gonna try to avoid any CT scans because of the contrast, or you're gonna go ahead and do a day of doing what's called a fluid reduction technique, where they give you gentle fluids for the whole day prior to getting a cardiac cath and a stent placement if that needs done. All right, so I got to give chloride a little bit of love because I feel like if we hooked up BUN and chloride, they would make a great couple. They really would. They would be, I feel like BUN is effeminate, and I feel like chloride, chloride seems like a really, really great guy that maybe never dated anybody ever and lives in his mom's basement. Because chloride, although very important, because I would never say that an individual or an individual lab in this case is not important, because it is. And it also is an indicator for other things like metabolic alkalosis and respiratory acidosis, depending on whether it's reduced or increased. I just need for you to know that I'm not going to worry about chloride. I have never seen a test that includes chloride, and that also includes my HESIs and my NCLEX. However, I feel like I just set myself up for failure. Do not, I repeat, do not go, Molly told me not to worry about the chloride or the BUN, because although I say that they don't matter, it doesn't mean that they don't matter to somebody, because somebody put that in a lab value for a reason. So just know the lab values of the chloride, know what it could indicate, and that should be good for right there, and walk over it and be done. Potassium, that's your big boy player. I look at potassium as like, I don't know, the football player in the high school that was voted most popular. I also look at cardiology that way. Us neuro kids, we're in the corner playing D&D, and we're going to rule the world someday. They just don't know yet, while those guys are, used car salesmen. So know that potassium is your big boy player. Know what causes you to have a lower potassium. Diuretics, right? Not necessarily all diuretics, because I can hear you guys going, not all of them. Okay, cool. I'll give you that. Spirulactone, it is sparing, and that's super cool. And you need to watch out for what? Potassium being too high. So there it goes. You still need to worry about potassium, because either way, it needs to be addressed if it's too high or too low. And again, these answers are going to pop up. Man, I promise you, it's on every daggone test that you're going to have. If potassium is mentioned, potassium is probably going to be your guy right there. So know those levels, whatever that looks like to you. If you notice, I pulled this off of a website that I thought was super good, because it kind of broke everything down for you, and I like that for you. This one says 3.5 to 5.0. Again, I was taught 3.5 to 5.3, and I think the other slide said 3.3 to 3.7 or something along those lines, or 5 points. Anyways, go back 2 slides and it's there. So everyone's a little bit different. Whatever your book says is what you need to do. Okay. Just keep that in mind. Whatever your book says, just go with that 100% of the time. So let's see, true depletion of potassium or apparent depletion. Yeah, we can shift into acid-base status problems. We need to watch out for what medications we give, because that is also going to be another proponent with how this potassium is going to work. And again, it deals with electrical conductivity of the heart. It's a huge deal. I tell this to all of my clinical people. I say, listen, what do we do lethal injections with in the United States? Potassium chloride, right? That's what we do to stop people's heart, is we give them high doses of that. So you've got to be really, really careful with this stuff. Also, you need to care about potassium, especially if you're giving IV piggyback, because it always says to give at 50 an hour. Never, I repeat, never let a resident write for IV potassium at 50 an hour. If you have never had IV potassium yourself, I have many times. When I know it's coming to IV piggyback, I get so scared, because there's always an idiot that will put it at the rate that the doctor says, because the doctor said to do it. And I feel like I am burning from the inside out. And you telling me to give me an ice pack is not going to fix it. And you telling me it's okay, it's supposed to burn, is not an answer, guys. And it makes me want to shake people lovingly. Shake them lovingly, but shake them no less, because none of those things are going to stop the incessant burn that is within your arm and travels up, and then all of a sudden your whole body's on fire. And I'm not being dramatic, because I am super tough and had 4 kids with not even so much as a Tylenol, and I would rather have another baby than deal with potassium going into my arm, if that makes any sense. So crank that bad boy down for the love of Pete. If you see that it's 50 an hour and it's going to peripheral IV, call your doc right now and be like, nope, I cannot do that. The patient cannot tolerate it. Because I promise you, guess what? They're not going to be able to tolerate it. So 9 times out of 10, when nurses say that, we treat it as a titratable order, because I always titrate it down before I even start. It doesn't matter how much you dilute it, unless you physically dilute it in the bag, which you physically can't. I mean, I suppose you could, but that would be stupid. Not stupid. It's just you can't. It would mess up your mixture too much, and it would cause more issues than it would do good. You need to remember, no dice with that potassium if it's IV. If it's oral, cool, let them take it. People complain about potassium because it dissolves in your mouth, and sometimes it feels a little gritty. I don't see what the big deal is, but then again, I'm built for tough, so I'm a little bit different, right? Like, I got an iron chin, a big mouth, and nothing ever bothers me half the time. So 3/4 of the time. So that's why I am the way I am. But sometimes these guys do get ate up about it, that they have to swallow them. Sometimes they choke and it's a little dramatic. Just try to do whatever you can to help them, and try to do whatever you can to explain to them if they have any burning at all, they need to stop. Stop, stop, stop. Stop. Hit the stop button. Do not pass go. Do not collect $200. Don't let potassium run hot. Period. Ever, never. Okay, I'm done. I'm done talking about it. All right. So there's your hypokalemia causes. There's your hyperkalemia causes. Also remember that false potassium elevations, if you have a lab draw that it is hemolyzed, it's going to create a problem with a false high potassium. Sometimes I've seen these elevations go like 9. And I was like, yeah, no, we're going to redraw. That's not a thing. So just keep those things in mind. You know your potassium. I don't need to tell you a ton. All your information is there about what medications are going to cause problems, what it's going to affect, how it's going to affect it. And the basic that you need to know is just your levels, what hypo means, what hyper means, and what that means to your body and what causes it. And that's it. And 9 times out of 10, it's your medication. So there you go. There's my spiel on potassium and chloride. All right, so incidentally, because we're talking about, hypovolemia, we're going to run into needing a urinalysis. So we're going to talk more about this when we get into renal, so don't freak out over the bacteria, the ketones, the nitrates, all the other stuff. What I want you to pay attention to is what the volume expectancy is supposed to be and what your urine-specific gravity is supposed to be. And I need for you to recognize what hypovolemia and hypervolemia is going to look like specific to your urine specific gravity, if that makes any sense at all. So whenever you are dealing with any type of deficit or too much, you either knock one or the other off, right? So either this is a sodium problem or either this is a fluid problem, and there's little middle ground, to be quite fair. So I need for you to know that if you're treating a fluid volume deficit, you need to look at all of your levels. You're always going to look at your serum sodium level, and then you're going to look at your urine, just barely a little bit, right? You'll look at your hematocrit because that's going to make a difference in the world. But again, your urine specific gravity, what we're trying to do is get a goal back of having that within normal range, which is 1.003 to 1.030. You guys are going to have to write that down in a post-it note and stick it on your bathroom mirror. I'm telling you, because that's what I had to do with this one, because it's so close in proximity to looking like one another. It's going to drive you bananas and you might mess it up. And I don't want you to miss a question or miss 3 questions on your HESI or whatever when it comes to urine specific gravity. And I saw that a lot on my HESIs. I probably got 3 or 4 questions about urine specific gravity. Some were about how do we fix urine specific gravity that's, too much or too little. It'll say something like, you got a patient who's being treated for fluid volume deficit. It'll be benign. And then it'll say, which of these levels is off or which of these indicates that it's effective. And if it says which of these levels is, appropriate for fluid volume deficit, you're going to look for your serum specific or your urine specific gravity that is off. And then if you're looking for has it been effective, you need to look at the number that's within normal range, and then all of your other numbers will be off. So again, whenever you're dealing with UA questions, you need to know these guys right here, sure, but the most important thing you need to know of all of these is what our urine specific gravity is doing. And then when we're talking about overload or underload, you need to worry about your serum sodium, I guess your BUN, gross, your creatinine, your hematocrit is always going to be a proponent, and also that urine specific gravity, like I said, is going to be your hot spot, and usually it's going to be your answer. And that's just for me looking at HESIs and looking at NCLEXs for 1.5 billion years and helping people get through theirs and doing all the things that I've done. So just keep that in mind, and that's all I got for this slide. So the ones that we haven't hit yet: phosphorus, calcium, serum sodium, mag, potassium we've hit a lot. That's easy. If it's too low, it's from diuretics more than likely. If it's too high, it's because of potassium sparing. or because you have significant issues that we're not going to get into until we talk about cardiac, right? So just make sure that you understand your parameters, like we talked about earlier, and make sure that you understand what they stand for. And here's the signs and symptoms of having too high or too low. So that's right there for you. Magnesium, it's a silent bust you in the face because it'll come back in neuro, and it'll come back when you're dealing with patients in OB, in motherhood and maternity, and it can cause a problem specific to seizures when you get out of the range of magnesium. For non-OB related issues, for neuro issues, we always worry because people will come in, they'll have deep like tendon reflexes, they'll have confusion, they'll have like not otherwise specified muscle cramps everywhere, and then we'll know, dude, we got to do a mag level because their mag is probably 1.5 or lower. We like to keep mags at 2 is usually where we like it in the world. Although when we get into like the 1.8 territory, Ohio Health, I know will order a mag. Oblinus Hospital, which is Ohio Health, which is in Athens, was notorious if you ever had one off by like 1.9, you were still given 2 grams of mag. Like, get over yourself, you're doing it, and it's the most annoying thing ever because it's the first thing in the morning. The last thing you want to do is hang an IV bag at 9 a.m. You just want to give your pills and get out the door. But again, this would happen, and it's because these reflexes and these reactions are so similar. We want to make sure that we kick mag out of the way because mag gets really serious once we start getting into the way abnormal levels. When we get into that territory, we're talking about massive seizure. We're talking about tetany that just won't quit. We're talking about tonic-clonics. I mean, it gets super hairy. So we'll talk about it when we get into neuro. Just right now, know what it looks like if you have a lower magnesium, because I get that. Let's see, we talked about that. Urine specific, we talked about that. Your serum calcium. Make sure that you understand the difference in highs and lows with that. Most people think calcium bone, and while that's super cool, I get that. There's far more going on with calcium than meets the eye. It's like your silent, cool kid that just kind of walks around and doesn't care what anyone thinks until it hits hard. These guys that have super low calcium levels, they will have the tetany, right? The contractions when you do the Trousseau sign. And the Trousseau sign is like you throw a blood pressure cuff on and then you inflate it, and while you're taking their blood pressure, their muscles will start twitch, and you'll be like, what in the world is going on with this guy's wrist? And you're going to think something stupid, or maybe they're making it up. You got to remember, you got to go back to calcium, because this is absolutely the reason that we're having these skeletal contractions and spasms, right? They're also going to be super crampy and super weak. If it's too high, they're going to be super thirsty and confused, nausea, vomiting, diarrhea, the whole gambit. It's awful. Make sure that whenever you see that kind of reaction, the first thing you need to do is jump on that serum calcium level, be calling your doctor and being like, look, here's what I just saw and it was wicked. So can you come look at them, because that's a problem. Obviously, sodium is a big deal because, when it's too low, you got these bounding pulses. You feel just hot and disgusting everywhere. You get dizzy. You're fatigued. You're confused. You just feel awful. When it's too high, you got twitching, seizures. That's a huge problem in the world. So you got to make sure you know those levels and know how to watch out for both of those. Let's see what else we got. Oh, your FOS. So your FOS is also a super scary one as well, because you'll have tingling of your lips, memory problems, thick hair out of nowhere, seizures if it's too high, and then if it's too low, you're going to be confused, you're not going to want to eat, you're going to have like systemic bone pain, which a lot of people will come in with this problem and they'll think, oh God, they've got cancer. No, you just got a really, really bad FOS that needs fixed. So keep that in mind as well, because those might come back to bite you as well. And I'm talking like NCLEX, I'm talking HESI. These lab values, you really need to do the post-it note on the mirror in the bathroom situation. When I didn't know what these were and I had to memorize them, and I had like a day and a half to memorize them because I didn't think it was a big deal until I realized it was a big deal, and I was dumb for not thinking that. I had to get a post-it note pack and put down potassium, right? 3.5 to 5.3, which is what I was taught. And then I would put hyper on one, and then I'd stick it next to each other. I used to use my mirror as like a dry erase board. for my entire nursing career while I was a student, and it did me some good. So I would encourage you guys to do the same, specific to these lab values, specific to your UA values, specific to your CBCs, your BMPs, your BNP, all of that jazz that we're all about to get into. Especially the big ones. Like I said, like the potassium, the mag's a big one, the serum sodium is a big one, the calcium's huge because of the Trousseau sign. You always see that one. Phos is a big one too. So just keep those in mind, because we're talking about issues with malnutrition, right? And anytime you have malnutrition or fluid volume deficits, you're going to be in a flux, right? And if you get severe enough, you're going to get what's called paradoxical movements, or what they call a flail chest. And you want to talk about a bad day, have a flail chest. Give it a Google. Look at what a flail chest looks like. You need to look at it at least once, so that if you ever see it again, you will know what to watch out for, and you'll know what you need to talk to the doc about, because things like that, docs listen to positive Trousseau sign. Docs listen to flailed chest and paradoxical movement. Docs do not listen to, hi, their calcium, I think it might be a little high, and then maybe confused. No, you need to be like solidly in your answer when you're talking to these guys, because they'll just kind of blow you off sometimes, like, meh, whatever, because they've got 30, 40, sometimes 50 other patients to deal with. So I get it. I get it on the other side. However, as brand new nurses, you need to make sure you get the big ones done. Also for the purposes of your exam, sure. But the bigger deal is for your patients, and to save them, because a lot of these guys depend on you and your knowledge to be able to do what you need to do so that these guys don't code. So just keep that in mind, guys. So when we're dealing with fluid and electrolyte imbalances and volume imbalances, these are the big three that I always see come back. Diarrhea and vomiting is the cause for fluid volume loss. It's the biggest deal. CHF and diuretics, it's always the biggest deal when you're dealing with hypokalemia, right? Dehydration always carries irregular pulses, just the basic stuff that you need to know, what I call the big three that you're always going to see in any type of NCLEX, any type of HESI, any type of exam. So just keep a mind out for those specifically. I feel like I've just beaten it like a dead horse at this point, so you guys know that you need to keep your eye out for these type of things, and you need to keep it out for your patient too, because these guys, some of these are very, very frail and fragile people. So if they have 3 or 4 bouts of diarrhea, it's not like you and I. If you have 3 or 4 bouts of nausea and vomiting when you're in your 20s, or in your 40s like I am, oh God, so gross. I'm technically 39, so in April I will be 40. But I'm not looking forward to it. It's just, it's daunting, right? Anyways, digressing. Keep your eye on these guys, because these always come back, always. So just make sure that you commit it to memory. And like I said, I think at this point we all have. So I'm done with the slide. Okay, anemias. Here's where it starts to get a little hairy, because there's a lot of different types of anemias. The good news is I can help you figure out what kind of anemia is the one we need to focus on, because it's always the same for any of the big three tests that you have, right? I'm just going to call them the big three from now on, so I don't keep saying NCLEX, HESI, and exams, right? So universally, the big three is going to include anemias, right? So here's what you need to know, and this is going to take you all the way until you're done being a nursing student and you go for the big test. So here we go. Pernicious anemia, B12 deficiency. Seen quite often in alcoholics. Seen quite often with people who get gastric bypass because they lose the intrinsic factor. Also, people who have H. pylori is another indicator. These guys, specifically the people who have the gastric bypass, will need B12 supplement for eternity. That is the thing that will not go away. Before, we used to have people who would just take daily B12 vitamins. Now we've realized that we needed a better concentration. So they have really cool, like, nasal sprays that they use to supplement someone who has that cobalamin or B12 deficiency that causes a lack of the intrinsic factor. So the intrinsic factor is secreted in the gastric mucosa, and it's required to absorb vitamin B12. So the whole reason isn't that they can't get the B12 or produce the B12. It's because it doesn't matter what you produce. I mean, inherently the body can't absorb it. So that's why you have to do it through oral mucosa. So when the client lacks the intrinsic factor, they're going to have the deficiency, which is treated usually by B12 injections. Oral supplements, like I said, they're okay. But the best way to do this is to go like nasal, because it hits the oral mucosa. Boom, we got it. It's in there. It's doing its thing. We're all happy. And that's basically all you need to know about pernicious anemia for this moment in time. We're going to get in depth with pernicious anemia, and there's a couple of other things that I definitely want you to focus on. But just so you're getting okay, I need to hit these bullet points for sure. I want you to read what that means to have pernicious anemia versus iron deficiency anemia versus hemophilia versus aplastic anemia. There's a lot of ins and outs and in-betweens for all of that, so just be aware. Iron deficiency anemia, we need to replace with iron tablets. So there's a couple of caveats when you're dealing with iron tablets. Iron tablets. I am Iron Man. You need to make sure that you are taking it with orange juice. Orange juice has a lot of vitamin C. It increases the absorption of the medication. It's a huge deal that we let them know, because a lot of these guys will take the iron supplements. They will either have refractory, like nausea, they'll have refractory diarrhea or constipation. It can go either way. I've usually seen it with constipation versus diarrhea. It has a weird smell to it. I know I'm getting super in depth here, but I'm just warning you ahead of time. When you know someone's on iron tablets, just, put a little dab of some type of something in the side of your mask on the inside, and just be prepared, because it's going to be something. A lot of times they'll tell you don't take it with water, because water really doesn't do anything for absorption. They tell you stay off of milk and tea and coffee, because those actually reduce the absorption, so you don't want to mess with that. Pineapple juice, you need to, if they decide that pineapple juice is a thing, there's this myth that any type of citric juice is going to be fine. It's strictly an orange juice thing. It's not a pineapple juice thing. It's not a cranberry juice thing. I'm not sure who decided that was a deal, but they've got it all messed up, and 9 out of 10 people on iron tablets think that it is just citrus, period, and it's not. Orange juice is your buddy. Nothing else really is, to be quite fair. Hemophilia, joint pain, swelling, change in color of stools, you bruise easy. So let's talk about hemophilia for 5 seconds, because I care about hemophilia very much. As someone who is a hemophiliac. I'm not like boy in the bubble hemophiliac. Don't anyone freak out. You're allowed to give me a high five, and I'm not going to bruise up. I'm cool. But it is a deal. So here's my hemophilia story, and give me a couple of seconds, because you need to watch out for this in people, and I think I mentioned it earlier in slides. So my hemophilia story is I grew up on a reservation, as you guys well know, and until I was 14, I didn't know the outside world existed. It was perfect. It was wonderful. And then I found Western society, and oh boy, was I in for it. So one of the things that I had a problem with very early on, when I hit, 15, 16, and I started having my lady time. Guys that are listening, so sorry. It's a thing. We're just going to have to let it go and deal with it. But you guys, I'm not worried about, because you guys are smart, and you guys know how to be kind. So it's not a big deal. I would cycle, and I would get so tired. Oh my God, so tired. And my skin would get green. My body just ached. I just dreaded it like the Black Plague. Sometimes it would be 2 weeks. Sometimes it would be 3 weeks. Like, it was just all over the place, and it was awful. And I remember passing out several times, and my mom going, "You'll get over it. Just go in your corner. You're being dramatic," right? I'm being dramatic. I can't freaking breathe. What are you talking about? So it got so bad that I had to get scoped at the age of 12, and they found out I had a bleeding ulcer, and they put an NG tube in me. Or no, I wasn't 12. I was 15. I don't know where I got 12 from. 15, NG tube, had to have it 3 times over the period of 2 years. Not fun, by the way. And they said it was this bleeding ulcer that was causing the problem. So they would cauterize it, fix it, go back to it. It would come back, da 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 da. This went on forever. And then it just kind of spontaneously stopped. So they figured, hey, we got it, no big deal. Go ahead and fast forward 4 kids later, and my oldest at the time was 14, and I heard a big thud one day in the bathtub, and it was my child who cracked her face wide open on the side of the tub, and I obviously freaked out, ran her to Wright-Patterson Air Force Base, took her in and said, what the heck? And they said, we don't know what happened. We know that she was orthostatic hypotensive. Yeah, you think? And I said, I don't know what's going on with her. And she was just as green as I was. And I mentioned these things. And as I was talking, I saw the wheels turning in the doctor's head. And I said, what's going on? He goes, I need to do a test and I need to do it now and she needs to stay over. And I'm like, okay, what's going on? She might need a blood transfusion. What do you mean? My 14-year-old needs a blood transfusion. What are we talking about here? So it comes out that she had von Willebrand, and I gave it to her from genetics. And now that my middle kid, well, it's not middle because there's 4, but my next to oldest, how about that, is turning the tender age of 15 in about 2.5 weeks. She's starting to have those problems too, so I've got to get her looked at. And some of these are so severe, like I said, when you crack your face wide open or you pass out as a child, that's not good. Be a good mom. Some of us didn't have those. And recognize that that's a big problem, because what they'll do is they'll put an IUD in these kids and the bleeding will stop and the problem will stop. And guess what? All of a sudden your kids can breathe when they walk up a flight of stairs. And I used to think I was being dramatic and crazy, and I was slowly dying. And my mother couldn't be bothered. So please, my good mommies and daddies, which I know are all of you, please be aware of that, and please be aware of that in your patients, because it might pop up for sure. It's popped up in the last 10 years. I probably have one or two a month that I suspect. So we test them for it, and probably once or twice a year I get a hit for it. And when you're talking about generations, I've got 4 girls, right? Like 4 girls. And that's a big deal when we're talking about something like hemophilia, especially when they cycle. And that's usually when people find out, if you're smart and you're a decent individual who takes care of her kids. But just keep that in mind. You'll never forget it now. So von Willebrand or factor 8, they're interdependent, but they work independently as well. Those are the baddies. And then your factor 5 is your opposite, which is your I create clots, which I also had a patient that did that. He was a wonderful 32-year-old male. And he came in with clots to his feet. He had to get one of his feet amputated. He had to get 3 of his fingers amputated. And he had a severe myocardial infarct at the age of 32. He, by all accords, didn't have anything else wrong with him. He didn't drink, he didn't smoke, he didn't do any of the bad things. And because he had the factor 5, he's missing appendages now, which is very unfortunate. So make sure that you try to pay attention to these signs, because some of these things are that serious. And guess what? We're not being dramatic if our skin is green and we can't breathe. These guys will have very low oxygenation, right? Like if I'm 16 years old or 14 years old and my oxygen is 90, that is not a good indicator that things are going well for me. And I know it sounds silly and you're like, but it's 90 or above is fine. No, dude, it's not 90 and above if you're not meant to be 90 and above. If you're 14 years old and you're anything lower than 95, I'm looking at you with a rock, like the rock raised eyebrow going on, right? I'm trying to figure out what jabroni kind of situation you have happening to you, okay? So there's my hemophilia talk. I'm done. Make sure that you understand joint pain, swelling. Oh my God, biggest problems ever. I would wake up and my hips would ache and I thought I was dying. Changing color of your stools, of course, that's going to go kind of weird. They expect it to be like a blackish blue because of the color of the iron, but it's also indicative of having blood in the stool. So you need to make sure that that is a sign and symptom that you need to A, educate your patient to watch out for, and B, watch out for yourself. And then bruising easily. It is not normal to bruise easily. You guys will constantly see bruises on me. because sometimes I forget to take my meds and I'm really bad about it. And you'll know when I have sparred because I'll come in and my arms are all lit up with bruises and y'all are going to be like, Molly, who beat you up? And I'm going to be like, technically I did, right? Because I'm the one that chose to do it. So I don't want to hear it. It's a thing. Make sure that you look out for it. Okay, I'm done. All right, aplastic anemia. The people who are at the biggest risk for aplastic anemia are the chemotherapy patients. I think of the aplastic anemia because there's so many anemias you have to remember, right? So pernicious anemia, that's B12, obviously. Iron deficiency anemia, that's pretty self-explanatory. How do I remember aplastic anemia? How about this one? Aplastic anemia is going to put me in a plastic body bag because this stuff will kill you, absolutely. It's a huge deal. You've got to watch out for it. We're going to get into aplastic anemia a lot more in depth because that's one of the hot ones that they hit you with on the big three. So make sure that you're paying attention to those for sure. Also know that when you have severe anemia, it really doesn't matter which type of anemia you have. What you need to know is severe anemia, you're going to have an increased pulse. You're going to have a heart rate that is in the 120s, 130s. You're going to have a change in color in your skin. And I even still have these problems. As a matter of fact, the next time we have class together, give me a pulse ox and I'll put it on and you're going to be wowed because my heart rate chills in the 120s normally and has my entire life. It's not a result of any kind of random medication I'm taking. It's just part of the fact that I'm just naturally a super anemic person, and that just kind of goes along with it. It's kind of sucky. So know what the signs and symptoms look like for just general severe anemia. Sickle cell anemia. So this one's controversial, guys. So as far as your textbook is concerned, they want you to make sure that you administer oxygen, and that's the biggest thing you need to remember for sickle cell anemia, because here's the deal. The cell is sickled, right? So the cell isn't perfectly round. It's kind of oblong and all over the place. They burst, they lyse, they cause all kinds of problems. These guys have incredible amounts of pain. It's miserable to watch. They tell you to put them on oxygen because you're losing oxygen binding capacity and you're basically going through an asthmaticus crisis, right? So the problem with all of these things is it's very controversial because a lot of times if you administer oxygen, you're causing more damage than help. And I will get into that when we talk more about sickle cell anemia. The big thing that you always hear about when you're talking about the big three is to know that you administer oxygen. Now that's a very controversial issue. So now we say administer oxygen at night while they're sleeping. But like I said, I'll get further in depth with that because right now it doesn't matter for the purposes of talking about what we need to hit hot spots on. So make sure your sickle cell is always going to come to the big three. Make sure you're reading that paragraph. It might be half of a page, actually. I want you to commit that one to memory. Commit your aplastic anemia. Hemophilia, you need to know the basics. Iron deficiency anemia, you're going to have to hit hard. Pernicious anemia, you're going to have to hit hard. This one of you guys send me a text. Give me a second, I'll get to you. Blood transfusions. Let me say my piece on blood transfusions, and then I'll back off of the slide. I promise. Blood transfusion reactions. You are going to itch. That's number one sign. That's fastest sign that you're going to get. You could also get flash pulmonary edema, which is very scary. You're going to get chest tightness if you have an anaphylactic reaction, and it happens within 15 or 30 minutes after the start. If it happens, if your patient complains of itching and redness, turn off. I repeat, turn off the blood, okay? I cannot tell you how many times I have had a nurse who is supposed to be there for 15 minutes, and I mean not 15 minutes after you started and it's still got tubing full of fluid. No. You stay there until that first drop of blood hits that wrist, because here's what's going to happen. Your nurses are going to spike your bag, and your bag is going to have a line of saline, right? It takes, if you're running 60 an hour, it's going to take you a solid, that blood tubing's got about 30 mLs in it, so it's going to take you half an hour just to get the blood to that person, right, off of that theory and that math. So here's what goes on. They turn it on, and it's still running the basic tubing. They're trying to get out of the door. They do their 15 minutes. They say the patient's fine. They walk out. Guess what? The blood hasn't hit their freaking wrist, and then all of a sudden, we get somebody hitting the clove blue button, and it's usually the family member because the guy's in there in flash pulmonary edema. He's broken out in hives. He's itching and freaking out, and it was because we didn't stay. So here's my piece. First off, stay in there. And if you need to even just kick all of that saline out of your tubing and just go ahead and put it on 500 volume and just let it push on through, buddy, go for it. Do that. What I usually do is I go ahead and just kick it right to the corner. I unclamp it, I let it roll hot, and then, dump into the sink until I hit that red. Once that red hits that wrist, that's when I hit the punch button, because I've had too many instances where this happens. And it usually happens in people who are on their first type of transfusion and they've never had one before. Or it happens in a person who's had, 8 or 9 transfusions by the time I get to them, because they have a massive GI bleed that they can't quite fix. So you've got to stay in the room for the 15 minutes and watch for a transfusion reaction. You have got to wait until that blood hits that daggone arm. And that is how that goes, and there's nowhere else around it. You've got to understand how this works. And I need for you to also know that if you see somebody that does it, not only do I want you to fuss at them, I want you to take it to your nurse manager. I never tell people to rat other people out. I'm telling you, with the way I was brought up in this world, that is not a thing. In this case, people will die if you don't tell on that nurse, because if that nurse has done it once, they've done it 15,000 times, and they're lazy, and they just want to get out of the room, and that is not, I repeat, not okay at all. Okay, I'm done saying my piece about that. I think we can move on to our other slides. When it comes to blood transfusions, that's a big 3 as well. The main thing is, what's the first sign? We just talked about it. The other thing is, how long do you stay in the room? We just talked about that too. And the other thing is, what do you do if you start to see a reaction in a person? And the answer is pretty simple. Turn the daggum thing off. Okay, you're done. That's it. All right, I'm done with the slide. So I want to go over heparin again, and I know that we talked about it earlier, and we understand all of the things, right, because I got into it pretty heavily. But I want to reiterate heparin because it's something that we do often as nurses. And I mean, it's something that we do often as med-surg nurses, but I'm not going to do med-surg. I'm going to do step-down. All right, cool. Then you're definitely going to get heparin. But I want to do dialysis nursing. Cool. You're going to do heparin there, too. Matter of fact, you're going to do it more than you would if you were med-surg. So heparin's always going to come back to you. Know the basics. Know that if you have someone who is suspicious of a STEMI, has an elevated troponin, an active chest pain, or factor 5, like we talked about earlier, which is a clotting problem, or a known DVT, the second you find out that patient has a DVT that's confirmed, you call your doc and you say, hey, you want to start heparin? The first time you get a person who is having chest pain not otherwise specified, they don't have any significant cardiac history, they're saying their arm is hurting, and then they have a trope that comes back, call and be like, hi, do you want to start heparin, right? Pulmonary emboli, same deal. Venous thromboembolism, same deal. You've got to get these guys on. Sometimes you're going to have to bolus them, which means you drop a whole bunch of it in, drop it like it's hot, right? Sometimes you will have to give them just the standard and then do an immediate heparin draw. You cannot turn off this heparin, okay? So a lot of people, this is a notorious thing that nurses and techs do because we're all trying to help each other out and we're all understaffed and we're all undermanned and we have way too many patients, is we will go into a room and whatever fluids they're on, we don't look at the bag because we're in such a hurry that we can't be bothered to look at a patient and see what's going on. I don't understand it. I can't figure it out. Whatever, I'm over it. So it happens. So you got to be aware of how to fix it. They'll come in. The patient will be like, I got to go pee. I got to go pee. I got to go pee. What do? All right, cool. You unhook them, and then you take them to the bathroom, and you got to sit there and wait while they're going to the bathroom. Well, 9 times out of 10, someone's going to call you on your Vocera. You're going to have to jump out of the room because the doc wants to go around with you because he's internal med, and that's what internal meds do. Even though there's absolutely nothing going on with the patient, you got to stand there for 25 minutes while he tries to make something happen because there isn't anything there, but they've got to feel important because they're internal med. All right, this is what happens, and then you walk away and you forget about that patient. Somebody else gets the patient and puts them in the bed, and everything's fine, only they were on heparin. Heparin only works for about 15 minutes, and then it burns out as if you did nothing in the first place. If you have people who are taking off the heparin and taking people to the bathroom, and then they get caught up in life, just like I do, if I go to the bathroom, I get stopped 3 or 4 times because I'm that person that everyone can go to and everyone knows they're not going to get made fun of or yelled at. please understand, don't be one of these guys, right? If there is a heparin drip going on, I better not ever see it hanging up and, screwed into the side port attachment and then up in a pretty little bow hooked on your IV pole. It should never happen, because these guys will die if they don't have that medication and they need it. And I just realized that this needs to get fixed. So that looks better. Okay. That's much better. So just keep this in mind. I always bring heparin in, even though it's not that big of a deal as far as the big three. It usually doesn't come around until we talk about cardiac stuff. It's a big three for me, and I'm going to make sure that you guys understand what that looks like, because you're going to run into this all the time and it drives you bananas. And sometimes you're going to have to get snotty with these people and be like, look, don't ever touch my patient again. If you ever have my patient and they got to go to the bathroom, don't ever touch my patient. Just come get me, right? And I've had to do that with a lot of nurses because I refuse to let somebody die. Little known fact, and I'm going to go ahead and knock on wood here. I have never, I repeat, never in the 10 years that I have been a nurse, and I've worked in many ICUs, I've worked in many COVID facilities, many thises and many that's. I have never had a patient die that wasn't anticipated to die on my watch. I've had patients die, that's for sure, but not during my 12-hour shift. And I believe that one of the main reasons is I am so close to my patients, just like I am close to all of you, right? And if you don't think I'm close to you, it's only going to get deeper. So go ahead and pull your pants up, because the flood's coming, right? The flood of emotion, because I think it's so important that we remember what we are as a species, that we are supposed to take care of each other and lift each other up and encourage each other. And that includes my patient population, because if I'm treating them like a human being that they are, and I'm treating them with dignity and love and respect, then anything that goes wrong with them, because I have that bond, that inherent energetic frequency, vibrational pattern that we have with one another, I know that something isn't going to be right. And I can usually catch it about 12 hours before someone starts to go bad. The first thing I do is I look at their labs for the day. I look at their sodiums, their potassiums, all the big ones that we talked about earlier. And if something is wrong right off the bat, I go and assess them. And if I've had this patient for 1 or 2 days, I'm going to know if something's off by a millimeter. I mean, seriously, it's that big of a deal. Because when you care about somebody and you love somebody and you have that unconditional experience with another individual, be it a stranger or be it someone you've known your entire life, you want to make sure that you do everything you can to check everything you can so that nothing happens to them. And as nurses, burnout has caused us to forget how important this is in the world. Matter of fact, when I was trained in nursing before the pandemic, obviously 10 years ago, I was told not to get close to your patients. That is and I'm going to say some bad words here, so, if you want to quote me on and get me in trouble, that's on you guys, because once I'm gone, well, then you won't have to listen to incessant rambling for hours. Whenever this happens with these people and they get in such a flux, you have to care about them, right? I know that we're supposed to be desensitized and we're not supposed to get emotionally involved with these guys. This is the dumbest thing I've ever heard in my life. We are in a profession where people are going to live and die by our hands, but I'm not supposed to get close to them. How do you guys figure that I'm going to keep this person alive if I don't know who they are, right? They're not Johnny on the spot number 206, right? Everyone always asks me, what's your patient's last name? I have no freaking idea, because I don't go by their last name. Their name is Dave or Susan or Mama Bear, right? Or, hey, beautiful. Like, I know that we can't use those names, blah, da, da. We can't because it makes them feel awful and we're taught not to use pet names. I'm sorry. I've never in my entire career had someone complain about me caring about them. Never. Never. And you know why? Because when you care about somebody, they want to make sure that you do whatever you can to continue to succeed. Because there's so few people in this world that actually, implicitly, and wholeheartedly, genuinely care about another human being, right? So I want you to be those people. I challenge you to be those people that stay on people's butts and you know when something's going wrong with your patient. I know when my patient isn't doing well. When they start acting funny, I'm going to go, what's wrong with you? Something's not right with you. I don't like this. Right? This isn't what you do. This is what you do, not this. And then I automatically start assessing. Just like when you guys start having trouble, I'll look you dead in the face and go, what's wrong with you? You don't feel right. And that's exactly what I say. You don't feel right, because I can physically feel your energy. And if it's in a flux, I'm going to start freaking out because that's my normal inclination is to go, what's wrong? What do we need to fix? Right? Which is why I am as psychotic as I am and, adorable, because who wouldn't love that? A helicopter mom indefinitely. So remember this, remember HEPA, remember why it's important, and then I'm done with the slide. I'm going to stop talking. Okay. So on this, if you notice, it says pneumonia, asthma, COPD, and there's nothing next to it hardly. That's because pneumonia, asthma, and COPD is such a long stint, such a long thing that we are going to need to go over it intently and intensely. I want you to read up on all three of these. You're going to see these so often, so ridiculously often, that you need to know how important and the main things that you need to work on. Asthmatics, I get those guys all the time, and I can't tell you how many of them smoke. I can't tell you how many of them are like, well, my perfume that I use, it's a light scent. Dude, it's still a perfume. It's still an irritant to your system. That's not how it works. How are you 40 years old and you don't understand your asthma? But I get it because I'm the one that, had von Willebrand for 30 years and didn't even know it until my kid passed out. So that's how they know. There's my answer. Pet dander, but I love my cats. Cool. You can love them from afar. You can watch cat shows on YouTube. I don't know what to tell you, buddy, because you keep coming in with status asthmaticus and you're wondering why. It never fails. It always happens, and it's always the same deal. COPD, you're going to find the obvious ones in the big three, which is basically going to be, hey, what do you do when someone's oxygen's up to 100 is usually what I see. So the question will go something along the lines of, what is it that you need to change immediately when visualized in your vital signs? And it'll say, blood pressure, whatever, maybe it's a little high, who cares? Heart rate, maybe it's like 115, whatever, because they're here for COPD exacerbation. Then it'll say oxygen 100%. Boom, there's your answer right there. All my people know COPD and oxygen 100% is a bad day because we're going to throw them into what? Respiratory acidosis, and we'll talk about that later, and we're going to talk about it in depth, so just know it's coming. Let's see what else. Pneumonia, yeah, pneumonia is a big deal too, because pneumonia is like the equivalent of like status asthmaticus for a person who has never dealt with it before. So it's kind of like having their first bout of it. So because they have such a high oxygen requirement, you have to give them small, frequent meals to conserve their energy, because these guys can't eat a whole heck of a lot, but they're also full on pneumonia. Most of them are older and they're immunocompromised because they are older adults with different conditions that would cause immune system wear down. So you need to make sure that you're giving them small meals frequently so that they can, take breaths in between. These guys are notorious for dropping their saturations from like 91 to like 82. Just taking a couple of bites. So it's a big deal that you pay attention to that and make sure that if they're 65 and older, they need to get their pneumonia vaccine as soon as they are eligible to get that vaccine. If a doctor says he is good to get the pneumonia vaccine, then give your man a pneumonia vaccine, because you are going to kill them if you don't, especially if they are in a nursing home. Okay? I know it's daunting. I know it's annoying. I know you got to put it in order. I know you got to wait for it to come from pharmacy. Guess what? Now they're in the refrigerator, so they're already there. I know you got to stick somebody and you don't want to deal with it. You got to give them a pneumonia sheet. You have to put a lot number in. You got to document all of the stuff and all the things, right? You got to watch them for 15 minutes to make sure there's no reaction, blah, 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 blah. And if it's not that, they're complaining about it. They don't know if you've had one in the last 5 years, blah, 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 blah. Call the nursing home. Take the extra 10 minutes, because what happens to these guys is they're what you call 30-day repeats, okay? So let's say they come in with pneumonia and they refuse the vaccine when they come in a second time. By the third time they come in, they've got it again, right? Because what happens in nursing homes, they all give it to each other, right? It is what it is. It's not great. Most nursing homes require a derivative of the pneumonia vaccine, but you can also write a waiver for it in many nursing homes. So it's not a mandatory thing, right? COVID is, but not the pneumonia vaccine. and I can't figure that one out to save my hair. So if you guys figure it out, let me know what that deal is about. Pertussis is usually thrown in there because most people don't realize how important pertussis is, especially with babies. Whooping cough will kill a baby. Period. Period, point, paragraph. Pertussis will kill a baby. And pertussis is something that runs around pretty rampant, doesn't really affect adults very much, doesn't cause a big issue. But you need to make sure that if you have little ones and you have someone with positive pertussis, that is a droplet precaution. A lot of people will get a pertussis patient and put them in there just standard, and I don't understand that. But it's not a VRE, right? It's not a C. diff. It's not an influenza A or B. It's pertussis, right? So that one always pops up for that reason alone, that it needs to be a droplet, because most people just can't be bothered with that, and I can't figure that out to save my life, but here we are. When it comes to oxygenation on patients, look, these COPDers, they need their oxygen. I get it. Here's what I don't get. These are actual conversations I've had with my patients. No, you can't smoke with oxygen on. Do you want to explode? I really had a patient who exploded himself, and he ended up on my burn unit at Miami Valley in 2018 with severe burns. Severe, like second-degree burns to his face. He burned his ear off, to be fair, and it was because he was smoking with oxygen on. And I chuckle. It's not funny what happened to him. It was awful. But I chuckle because how do you have COPD, and how are you oxygen dependent, and how are you gasping for air? And the first thing you think to yourself is, man, I sure would like some tobacco product so that I can inhale it and make this problem that I have even worse, so that I physically choke to death. I will never in a million years get it. If you guys understand it, please explain it to me. I understand that it is an addiction. I understand that it is incredibly serious. I'm going to go ahead and tell you guys something I shouldn't tell you. 1 billion years ago, I used to be a smoker. And then when I watched somebody die of lung cancer, I stopped, because guess what? That is the most miserable death I have ever seen in my entire life. So, ta-da! Cured, right? And all I had to do was just walk away, deal with being angry for about 30 days. Every now and again I get a craving, but then I usually get busy with something, like doing these daggone slides. And by the time I've talked for an hour and a half in the history of 24 slides, I don't even think about it anymore because I'm so exhausted. So there, change the addiction and you're good. So we got to remember these things. No, you cannot smoke with oxygen on. I feel like I'm going crazy, but I really have these conversations. No, 80 feet of oxygen tubing is not a good idea. Like, how do you think you ended up in my ICU? And everyone goes, well, how could the 80 feet of oxygen tubing have anything to do with anything? Okay, cool. So think about this from a logistics perspective. If I am giving a liter of oxygen and I am traveling at 80 feet so that I can get to the front of the house, so that I can get my mail, how is that going to be an issue? How many things can pinch off that tubing? Am I really getting my liter of oxygen? Furthermore, if I'm getting a liter of oxygen and it's spread out over 80 feet, is it truly a liter from a physics perspective? The answer to that is no, it is not. But I won't even fight that one. I will just use the simple problem with things rolling over it, people stepping on it, it getting twisted and turned up and things. My older people who are my age, who aren't older people, they're just, older than the young ones. Back in the day when we had our phone cords, remember how we used to get on their phone with our friends and we would turn around in a chair because we were excited to talk to them, and what would happen? We would trip over our phone cord because it would get stuck around us. It's the same concept with 80 feet of oxygen tubing. So no, you can't. And also, what do you mean you haven't changed your nasal cannula and tubing within like 2 years? Why do you think you keep getting infections? Hey guys, you're supposed to clean these things once a week with soap and water. Did nobody know that? Apparently nobody knows that. It's a thing. It needs done. It's crazy that we're not doing these things. I don't know why we haven't taught them these things. I got no answer for that one. But these are conversations I have to have often, and that we need to make sure that we are reinforcing often. No, asthmatic, you can't have your pet right next to you. It is a trigger for you. No, you can't go move to Georgia where it literally is yellow cars everywhere during the month of July and August because it's pollen area time and you physically have to rinse your car to remember what color it was, that is a trigger for your asthma. It is a problem. I think I have beaten that one like a dead horse. So make sure that you are letting them know it is not appropriate for them to have 80 feet of tubing running around, and it is appropriate for them to clean their daggone nasal cannula that they keep shoving in their nose, or they're going to get an infection, and let them know, no, you can't smoke. That's crazy. Why would you do that? Okay, anyways, I'm done. And also make sure that when we have these patients, because their oxygen can fluctuate so often, if we don't have the opportunity to do full-on nasal cannula, or not nasal cannula, full-on O2 sats that are continuous, and we don't have a continuous pulse ox option, if we aren't able to do that every so often, I like to do it every hour and spot check it. If I'm in an ICU especially, it's not a deal, but if I'm in a PCU or a med surge and I get floated down, a lot of times they don't have the continuous pulse ox. You need to make sure that you're delegating those things to your tech. Don't be afraid to delegate. Let your tech know what's going on and be like, look, this person needs an hour-long spot check, and I need for you to keep an eye on those. And if you trust them, which I certainly hope that you'd be able to, you need to keep an eye on these things and keep an eye on these people. Influenza is also a big one that we're going to talk about. Because again, we're going to have those O2 levels that need reported from our techs, and we also need to be aware of the fact that we need to check their PaO2 levels, because those are indicative of having trouble breathing. And sometimes you could have a low PaO2 level, but a relatively normal SpO2 level. And we'll get into that when we get into the lecture about influenza and how that looks. So I just need for you to know that those things are coming around and coming about, and that's the thing. Aspiration pneumonia is also a problem. The people who are most at risk for this are people who have confusion, head trauma. I see a lot in stroke, decreased level of consciousness because of post-surgical issues like anesthesia, and people who are post-bronchoscopy. You need to certainly wait for these guys. You need to keep these guys in PO for sure, because what happens is if they have shortness of breath and they have like a watery cough, you know they're dumping in their lungs the second they take something. So I'll give them the water test when they come out of anesthesia, or I'll give them the ice test. And that's when I give them a couple of chunks. And at the second I hear them cough, they're done. They are absolutely done. And I am calling speech therapy to evaluate them. You need to know this because aspiration pneumonia kills a lot of people. And it's not just old people. That's a common myth. And it's not just stroke people, also a common myth. These severe head traumas that you get on the 4th of July when everyone's playing with firecrackers and, you know, someone's trying to run from one and runs into a tree, which was an actual patient that I had, by the way. These severe head traumas will cause confusion, and it will tell the brain to tell the body to forget how to swallow. Which is why confusion is also a big deal. So people with UTIs, big problem. People who are post-bronch, you got to be super careful with these guys, because the second they start coughing, guess what happens? Things start bleeding. And when you're dealing with a bronchoscopy where they are physically going into the carina of the lung, right? Like where the base is, where they both Y-site together. And then they usually dump over to the right to do their bronch wash, right? These guys, because they've had pieces slit for biopsy and all of that, the second they start coughing, they usually start bleeding. And guess what? Blood is not meant to be in your lungs. That's a bad day. So if they start coughing, be done. Make them NPO. You're done. We're not doing it again. Anticipate if they are short of breath and they have a productive cough, immediately get a chest x-ray. Immediately get a chest x-ray, because that's going to let us know, do I have blood in the lungs? Do I have fluid in the lungs? Do I have a pneumonia process? Do I have 15,000 things going on that I don't know? And you need to rule those out, and you need to do it quick, because remember, you only got a couple of minutes and then you can't breathe anymore. That's the problem. So keep all of those things in mind. And boy, tuberculosis. Tuberculosis is a big deal. Which is funny. Here's why this is ironic, because tuberculosis is something that we get in the big three, and they hit it hard. I mean, hard. I mean, I've never known more about tuberculosis than I did in nursing school, because You got to know all the things, right? You need to know, what induration looks like when you're doing a tuberculin skin test, right? So 10 millimeters or greater is a problem. That's when we have a confirmed quote unquote positive or a preliminary positive, right? So what really does it is the bacteriologic testing, or the acid fast bacillus test. That is the acid fast bacillus test. That's the okay to call it confirmed. And make sure that when you're doing this bacteriologic testing, they have to have multiple sputum specimens for 3 consecutive days. And that is when they're also checking for progression and or completion of that therapy when you're doing therapy. It's also a big deal with tuberculosis because it's highly contagious. So I may see 3 tuberculosis patients a month, which is not a lot, because you got to think, if I work 6 days a week as a nurse, which sometimes I do, but not now because I'm a teacher, so 3 days a week times the upwards of 6 patients a day, and then you do it, that often, you run into a lot of patients. So to get 1 to 3 tuberculosis patients in an inner city area, that's not very many. Sometimes, like when I was at Valley, I would only get 1 tuberculosis patient maybe every 6 months, and everyone freaked out because it's such a virulent process. People just pick it up, and it's always in your homeless shelters. So it's a big deal. If you are a person who has HIV, AIDS, transplant, you're immunocompromised from sickle cell, whatever, we consider that 5 millimeters in duration, and you need to go ahead and get that followed up immediately, and you're considered contaminated, and you are quarantined, and the whole 9 goes through. When you're going through your treatment and you're taking your INH for the tuberculosis, that stuff is incredibly hepatotoxic. So we always tell those guys, don't you even think about drinking. Don't you even, sorry, I'm yelling at a cat because they're clawing on my couch. Okay, back to it. I tell them, don't you even think about drinking. That is not even an option. This stuff is so hepatotoxic. So keep that in mind as well. Know that when you have a patient that coughs and their sputum is bloody tinged, that's an indicator for tuberculosis. Did you guys know that? Oh my God, that's so revolutionary. So make sure that you're paying attention to those things, because as silly as it is, we need to make sure that we're monitoring those liver enzymes. We need to make sure that we're paying attention to bloody sputum, even if it's a little bit, like it's blood tinged. It could be a broken capillary, sure. It could be the result of a bronchoscopy and someone's coughing, like we just talked about. But if you see blood coming out of somebody and they said, yeah, I was just in Guatemala, or yeah, I was just in Nepal, or yeah, I was just anywhere that is not an area where tuberculosis is monitored by the CDC as heavily as it is here, you need to go ahead and hit that red hot flag button to your doctor and let them know, hey, they've traveled out of country, they've been there for X amount of time to visit their family, and now they're coming back and they're coughing and they got a little bit of blood in it. I don't know how to make of it. What do you want to do? And then immediately we're going to start testing for that, just as a precautionary method. So keep those things in mind, and we'll get into tuberculosis later. Like I said, this is a big 3. Tuberculosis, you will never talk about tuberculosis so much in your life. And then when you're done with nursing, you may see it once every 6 months. And then you'll be like, why did I work so hard on that? And it's because it's that virulent. So just keep that in mind and just, deal with it. We're going to get through it. It's okay. All right, I'm done with the slide. Okay, so here's some little respiratory nuggets that I feel are super important, because these are things that we don't talk about often enough, and these are things that come back to bite you in the nursing world all the time. So I feel it's very important to talk about these. So anytime you have pulmonary edema, anytime that you have a CHF patient, anytime that you have a patient who is on narcotics, they need to be continuous pulse ox. Or if you don't have that, like I said in the last slide for 18 minutes long in my rant, make sure that you are delegating your tech to do frequent spot checks. I like to do them every hour if I'm on a med surg or a PCU. If I'm on an ICU, it's not even a discussion because it's going to be there regardless. Pleurisy, you're going to see often. Pleurisy is so painful. I've had pleurisy before. I had pleurisy while I was working at Miami Valley and thought I was gonna die. I didn't know what was going on. Pleurisy is, it's like rubbing sandpaper on your lungs. Every which way that you move is just the most killer bronchial pain that you'll ever experience. I'm not being, dramatic when I say these things. It's so incredibly painful I could barely walk. The only time I've ever missed a day in my entire career experience, and that includes, prior to me being a nurse, was the day that I had pleurisy. I had to leave at 3 o'clock, and I had to exchange my patients over to a person for the 4-hour shift, because we do things in 4-hour blocks in hospitals, for a total of 12 hours. So the one time I left my post, the only time I've ever left my post, was with pleurisy. So the main thing that you need to teach them is they have got to splint, because when you cough and you have pleurisy, you are afraid and crying before you even cough. You know the cough is coming, and you already start crying. And I physically cried. I didn't think I could cry. Asperger's, emotions, it's not a thing. I didn't think I could physically cry until I had pleurisy. And the act of me knowing a cough was coming would make me weep like a small child. So please understand, you need to let them know they have to get a pillow and put it to them before they cough, much like a person with a broken rib from boxing. It's the same concept. You've got to lean into it, or things will juggle around internally, and it will make you feel like you want to just be done with life, period. Because it really is that incredibly painful. So that's pleurisy in a nutshell. Really important. Influenza, shortness of breath, start oxygen. Come on, man. You guys know this. If they're short of breath, you start oxygen. Now, here's the PO2 kicker. SPO2, you can have an SPO2 of, 88, 89, 90, and then have a PaO2, which is the partial pressure of oxygen that's in your arterial blood. It can be super duper low. And this has to do with the lungs not properly oxygenating the blood itself. So this is where the problem lies. So the PaO2, it can be in the 50s, and this is a big problem, right? You've got to do something about that, because obviously it's lower than the 75 to 100 level. So if your PaO2 is bad, you might as well just give up the rest of it, because it doesn't even matter, because you're getting oxygen, sure, but you're not getting the level of oxygen in your arterioles to take care of systemic release. So keep that in mind. PaO2 is completely different. You've got to monitor that. If it's too low, it's a no-go. How about that? There's your rhyme for that one. URIs, upper respiratory infections. Whenever you have an upper respiratory infection, you know it's coming, because you just can't get right. I call it the can't get right disease, because you're shuffling, you're moving around, you're restless, you're kind of irritated, you don't know why, you don't know what's going on, you kind of feel a tingle or a tinge. You kind of feel a little bit of pain when you breathe in real deep, so you breathe in deeper to see if it happens again. Like, that's an upper respiratory infection for you, so keep that in mind versus a lower respiratory infection. We're going to get into the lower and upper respiratory infections as we move along into the bigger slides, just for purposes of knowing what to go ahead and start studying on, since these things are like 265 slides a piece. Oh my gosh, I don't know how I'm going to get through it. Make sure you're keeping that in mind and putting that in for a bullet point. Read that paragraph and a half, URI versus LRI, or lower respiratory infection, because there is quite a bit of difference, and you will need to know the difference between the two. Management for all respiratory issues, narcotics, yes. So here's a little known fact. We can throw someone into an acidotic state from too much CO2 not blowing off in a perfectly normal patient. What's the kicker? We give them a PCA pump. So this happens when people have appendicitis. This happens more than not with them. Pancreatitis is another one. Sorry, I need a drink. So with these guys, you have to be careful, because if we lower their respiration rate, it's as if they're a COPDer. And if I'm giving narcotics and I'm giving you a PCA pump and I'm giving you Dilaudid that you can push, and you get, 0.2 every 15 minutes, and then you lock out, at a total of, 2.5, and then I'm giving you in-betweens for breakthrough pain, and you're still able to let me know you're in pain, and I can legally still give it to you, and you're still talking to me, so I do give it to you. You can get these guys so sedated, especially if they have kidney issues, because remember, it takes longer for that medication to process and burn out of the system. After a couple of doses, these guys start having respiration rates. They'll be like 12, 14, then it'll go 11, then it'll go 10, then it'll go 9. You'll go in there to go ask them if they need any more medication. you'll realize the respiration rate's 9. You'll do their sternal rub, and I swear you can punch them in the teeth and they won't even budge, because we have put them in a state of being comatose, not because of the narcotic necessarily, but created by the narcotic. We have created an acidotic state for this patient, and we need to do ABGs, and we need to kick them off of that, and we need to throw them on BiPAP like quick, because when the lungs go, other things want to go with it, and it's just a bad deal. And again, we'll get into that in the 9,000 slides we have to go over. Just make sure you're reading and walking over that topic and understanding that concept. Okay, so blood gases in Rome made easy. So I'm going to go through the whole shebang about blood gases. It's going to be a thing. Rome is the easiest way that I've ever learned how to do it. Someone showed me some crisscross applesauce, tic-tac-toe business. I don't know how you guys figured that out, but you know what? I'm envious. If that works for you, do that. There are some that do the band shirt button method. That one works pretty cool. I'm happy with that one. But I just know Rome because Rome is quick, fast, easy for me. Again with the drink, sorry. Well, let me do it. Okay, there. So, here's the easiest way to remember it. If you get so scared when you're in the middle of testing and you can't remember what goes what, how, where, who, what, remember these 4 concepts, please. Respiratory acidosis, classic guys, COPDers, okay? Respiratory alkalosis, classic guys, hyperventilation from panic attack. These are the big 3 that you'll see on the big 3, right? Metabolic acidosis. This is liver failure. This is cancer. These are alcoholics. These are marathon runners, right? This is my dude that, was eating Explode. Oh my God. By the tablespoon as a pre-workout so that he could look buff and tough and beautiful, because he is tough as he, paints himself brown to show more muscle and shaves his entire body. There's nothing manlier, in my opinion, than looking like Tan Mom, but whatever. These are these guys. And then metabolic alkalosis. Think of anything that is related to hypovolemia. So diuretic use, hypokalemia, vomiting vigorously, C. diff, and diarrhea, right? Like that whole gambit. And if you can remember those bits and bobs, every one of these questions goes as follows. A patient who comes in with COPD exacerbation, the second you hear that, unless they magically are vomiting or pooping all over the place, that your buddy is going to be respiratory acidosis, okay? Same deal. You're going to get alcoholic comes in with bizarre symptoms and is nauseous. He's withdrawing from alcohol. What is this disease process? Boom. Metabolic acidosis. You know it because that is what alcoholics do, and that is what they are known for doing. Same deal with metabolic alkalosis. Same deal with respiratory alkalosis, right? These are the people freaking out and hyperventilating like you guys when you took your first exam, and I watched you with them respers way too high, and I was like, y'all need to chill, and I did my little namaste pose that I did at you, and I looked at you, and we locked eyes very briefly. So remember, you remember these big 4. If your numbers get all jumbled up in your head because you're in respiratory alkalosis or trying to, just remember, find your disease process, see if anything changed with that disease process or there's anything in addition to, and if there's not, go squaw for the big 4, and that's it, and you got it, and don't even stress over it, okay? So that's the biggest tidbit and nugget of information I can give you for this, because these are the classics that you're going to see on any of the big 3. All right, here's my rant on blood gases and monitors. So I don't like monitors. They're a good tool. They are not an absolute. Here's an example. Oh my God, my patient's asystole, and they go running in to grab a code cart, and I just walk in and I go, hey, you feeling all right, buddy? And they're like, yeah, I'm cool. Why, what's up? And I'm like, nothing. There's going to be a girl coming to run for you in just a second. And I walk out of the room, and then I stand at the nurse's station, and I put on a really sarcastic face of excitement, and I put my hands in my chin, and I just sit there and wait and kick my feet as if I'm hearing a story that I'm really enjoying. And the nurses usually get really angry. If you don't believe me, the few of you that have worked with me, share the story. You've seen me do things like this all the time. I don't know how I'm still a nurse, because HR should have eaten me alive. I think it's because I'm a traveler. Anyways, digressing. So when I say these things to joke, but I also say these things to let you know that what you see in front of you is not necessarily what is real. If someone says that they have 160 heart rate on your monitor, you need to go do what? Check your patient, okay? Because your patient is real. The monitor has flaws. Oh no, but it's a GE. I don't care. It's not 100% appropriate. Here's how. I have a patient who has Parkinson's syndrome who's trying to eat. What do you do when you have Parkinson's? You shake. We'll get into that with neuro. Oh my God, I'm so ready for neuro. I'm so excited. Anyways, so they shake. And when they're eating, they're shaking close to their what? Chest. And what happens when they're shaking? They bump their what? Chest. And when you bump your chest, guess what goes off? Your leads. And it interprets that as your heart pounding because it is supposed to resonate with all vibrational patterns. So you will have someone that looks like they're an SVT with a 170 heart rate, and it's just Sam in room 204 who's eating his breakfast. And you are dumb because you're calling a doc saying, my patient's heart rate's 170. I need low pressure immediately. And they're going to go, oh my God, yeah. And they're going to give it to you because they're a resident doc and they're just on call for like 6 hours. So they're going to give you whatever they want so they can go back to sleep in their beautiful little sleeping bag in their physician lounge. And you're going to go run to go get their low pressure and you're going to dose it to them. And their blood pressure is going to tank and their heart rate is going to tank and it's going to be so bad. And I say these things because that absolute thing happened about 3 months ago. And no, it was not me. I am not crazy. It was a brand new nurse, baby dolls, because that is the thing that will happen to you because you trust people implicitly when you start and you haven't gotten that tough exterior quite yet, but you will. And until that day happens, we need to be aware of these things, okay? So if my monitor says my heart rate's 170, what I need to do is go, let me go see. And I'll walk in there, and if I'm looking at them and they go, hey, what's up? I know their heart rate is not 170 because that is not how they act when their heart rate is 170. So I'll do a quick pulse check. And then I will hear people run in and go, your heart rate's 170. And I'm like, really? Did you check the leads? Did you do anything? Like, if you just check the patient, it takes 30 seconds and then we can figure out if we need to call the doc or not. I can vagal them down. I can do, jugular massage, which isn't recommended if you're not a doc, so I wouldn't even talk about that, and I'm not going to. There's a million things you can do to bring that heart rate down before you even get on the phone with the doc. We'll get into that when we get into cardiac. But for right now, check your patient. Who cares about the monitor? If you get a left lead off and it's just bounced off of you, which is your top left lead or your red lead, if that red lead is off of you, you are in asystole. Did you know that? Did you know that the monitor says you are dying if you have that lead off? So that is how ridiculous monitors are, in my opinion, and that's how you need to watch your patient. So if your patient's in obvious distress, they're breathing shallow, they're hyperventilating, right, which is the opposite to the equal, and they're on multiple liters of oxygen, we might be making them worse. Like we just said earlier, you've got to get an ABG so that we know we're not throwing them into an acid-base imbalance. So make sure you're watching out for these things. If your pulse ox says that your patient is 70, know that pulse ox could either be accurate, which is not good, inaccurate because that finger probe has been on for days, or they're pulling it off because it's annoying them, or it's unhooked because they're in the bathroom but it's still rating 70%, and I can't even tell you why that's a thing, but it happens a lot. For my techs that have worked with me, you guys have seen the most bizarre, crazy things ever because for whatever reason, I'm just attracted to, it's like a magnet, the craziness just comes toward me. So these things, they happen, and I'm telling you so that you don't make a fool of yourself when you freak out and you see this for the first time. Just go check your patient. Do a spot check pulse ox, do your finger first, and then use their finger so that you know yours is working and theirs isn't, and then go from there and look to see if they have respiratory distress that is obvious, because if you have a 70% oxygen saturation, you're going to be confused and you're going to be trying to take big gasps of air and you're not going to be able to walk to the bathroom and be like, hey, can you change my channel to 24? Steve Harvey's about to come on. I'm ready to watch it. So just keep those things in mind. Okay. So the reason I put these slides in is because it always reminds me of somebody that was near and dear to me. So DIC. DIC is disseminated intravascular coagulation. It basically is a burst of clots followed by a burst of platelets just failing to be platelets, and then you bleed out of every orifice. And when I say every orifice, I mean you're bleeding out of your eyes, you're bleeding out of your nose, you're bleeding out of every capillary in your body. You are oozing blood. It is a slow process, but it starts off with you having this massive coagulation. Remember a couple of slides ago when I talked about people with hemochromatosis and how I got really nervous? Those guys, as well as people in DIC, will start presenting with these clots while I'm trying to give them an IV. Or when we try to do lab draws, we can't because it just clots as soon as I get it. Those guys scare the crap out of me. You need to be scared the crap out of somebody if you see it. I had a beautiful patient who was intellectually disabled and was born with a noxious brain injury, so they were not able to speak. However, this patient would talk with her eyes, and we had many conversations. And though she was not able to speak to me, we communicated through the eyes, and we were able to smile, and we loved to play practical jokes on people. She was paraplegic because of the noxious brain injury, and basically was there, laying there for eternity. And the only communication she had with everything around her was through the face. I say this 1,000 times because this is why it made it so difficult to find out what was wrong with her. And by the time they did find out what was wrong with her, it was too late. I was a nursing student. I was a tech at a place in Dayton that was specifically for adults who had intellectual disabilities. Sometimes I had babies that were there as well. This patient was 17 years old, and I adored her. She was my favorite. She used to play tricks on people all the time. She would pretend that something was wrong, but nothing was wrong, and then she'd smile. She just wanted you in the room, right? I had so many people there. I had someone that got hit by a train there that had a brain injury. I had a little kid who was abused by her parents. And was trach pegged and vented. There were just so many things, so many crazy things you would never expect to see. And I picked that place because I knew that I needed that foundation. And let's be honest, guys, intellectual disabilities, cognitive impairments, autism spectrum of any form, straight up autism, those are my tribe. Those are my people. I speak the language. I don't speak it fluently, but I speak it enough. To me, it's no different than a southern person versus a northern person having a conversation. So I gravitate to them. They gravitate to me. We know our blood. We know who we are. We find each other. It is what it is. It's a beautiful thing. So this particular patient was fine, and then started acting weird, was a little more grumpy. It was a resident facility. She had lived there for several years. So she wasn't spiking a fever. She didn't have any increased respirations. She was just acting weird. She just wasn't acting like herself. She wasn't her funny, haha, making a joke, smiling type of gal that she normally was. And again, she couldn't move. She couldn't speak. She could only just track eyes and smile for whatever reason. So I was gone for a week, and I came back, and when I came back, I went to go see her, and she was oozing blood everywhere. It was coming out of her eyes, it was coming out of her ears, it was oozing through her pores, through her nail beds. It was the most god-awful thing I had ever seen, and I went to go run and get somebody, and by the time I came back, she was vomiting whole blood, and she died right there. DIC is that serious. What had happened to her was she had severe complicated sepsis, and because we couldn't communicate with her from a regular human sense, as I put it, I always talk about the humans, right? Me and my kids all do, because we all have Asperger's, so we talk about what we need to do to make the humans like us, because sometimes it feels like we're from a different planet. This patient, this resident, who I am continuously stuttering over because I had an emotional bond with this one and I loved her so very much, and because I'm trying not to say her name just to keep her privacy. It was the hardest thing that I had to watch, and I lost my entire family to COVID, as you guys well know. So it was the most gruesome experience I think I've ever witnessed in my entire existence, and I wish I hadn't, but at the same time I was glad I did because I was there and she wasn't alone. So make sure that you understand DIC. It's a big deal. If you have a patient and you're doing labs and their blood is so coagulated that it's coming out in clumps, in clots, you need to be getting a hold of your doc immediately because this could be DIC, especially if they're there for sepsis. Okay, this is how it starts. It clots, and then it just pours like water everywhere. And that's that. There is no time to save them. There is no saving them when they get to that point. They're done. So that's my 6 minutes of that talk, and I appreciate you listening to it. Okay, so cancer. Nobody likes to talk about it. It always reminds us of somebody that we lost. There's 1,000 of them. They all sound very similar and yet have something that's like a unique process with them. Multiple myeloma is one that you're going to see in the big three because of the calcium dump that happens with them. And basically it's because when the bone breaks down, your calcium is the deposit that's left. It's like eating a sandwich and dropping crumbs, or like eating a taco and dropping little bits and pieces of the shell because you're a messy eater, right? Or just because, hey, it's a hard taco, it's what it does. So you need to know that when that happens, what's happening is it's releasing all of those calcium fragments into your blood, and that's why you have an increased serum calcium. It kind of reminds me of a thyroid storm with the parathyroid hormone, and your parathyroid just kind of going stupid. It's the same concept. So you need to make sure that you understand that they are going to have an increased serum calcium, yikes. And also know leukemia. Leukemia is a big deal when their neutrophils get low and their temperature is elevated. Anytime you have someone with neutrophils under 1, right, you've got to watch those guys like a hawk, because even a small low-grade fever, like 100 on the dot or above, you've got to go intervene with that, like quick, fast, and in a hurry. And Tylenol isn't necessarily going to be the answer for that, like it would be for, a kid. I would leave, if it were a grown adult, it was 100 on the dot, I would just tell them to drink cool fluids and, take Tylenol, be finished. But with these guys, we got to do a little bit more. So these are the ones I want you to focus on while I'm doing those 900,000 slides I'm doing. I want you to read about the different types of cancer, but these are the ones that normally show up in the big three. So I want you to really, really focus on reading those hot and heavy. Okay. Okay. Math. We're almost done, guys. So number 1, there's nothing super scary here. I'm not here to trip you up or mess things up for you. You will need to know your military time. You need to know how to do your GTT calculations, period. Right? You need to know how to cut a pill in half, right? So if I got a pill and it's 500 milligrams and I need to give the person 250, you need to know that that's half a pill. Okay? Like, I don't know how else to say it. It's going to be much simpler this time around. I don't know why it just turned out that way. But you need to know all of your little calculations that we've been getting. I don't think it's going to be any different than it was the last time. You do need to know the big GTT calculation that everyone hates to do, but I'm sorry. You just need to get it done and get it over with and get through nursing school, because it does come back to bite you, but you have so many resources, you almost never use it. You'll have pharmacy to tell you what the right GTT rate is. And it's always funny when you tell them, hey, this is the GTT rate I think it is. Can you calculate it for me? Because those guys, they always like to boast on, how they've got it all on lock with the antibiotics and they know about this and that and the other. And then you ask them to do a GTT rate and they're so used to using a calculator, they do the, and then you hear them ruffle stuff. And then occasionally they'll put you on hold and you just laugh on the inside because you know they're panicking. So know your GTT calculation, know your military time. You're going to know all those things. Those are very important. All right, final thoughts. So we all know the drill. Follow your recipe I've given you. Pay attention to the things I say. If I say them, there's a reason I'm saying them. If I hit it hard and I go ridiculous with the things that I say, there's a reason I say it, right? It's not just to hear myself talk. I really don't like to talk. I'm an introvert. I have Asperger's. Talking and communicating is not my forte. Ironically enough, I do what I do for a living. So go figure that one out. I guess me and my kids are trying to get cool with the humans, right? So make sure you're doing those things. I feel like I don't even need to say anything else. So don't eat yellow snow. Pay your taxes, the IRS. They're no joke. Know that I love you and I'm proud of you and I care about you and you're going to do great. Know that you need to focus on the things that are common occurrences in the big three. If I say the big three, pay attention to it because they're going to be on the big three. It's a big three thing, right? And I want to prep you because I know you're not doing this on our HESI this time, but it is coming. And when you do have to do the big three and you do have to do it with MedSurg, there's a lot. And I'm trying to teach you for these exams, sure, whatever. I'm trying to teach you for the HESI, sure, whatever. But the NCLEX, buddy, it's going to come back and get you all over again. So if I'm telling you, it's because I've read enough NCLEXs, I've read enough HESIs to know that these are more than likely going to be on your exam. So there's that. I'm proud of you guys. I love you all very much. I'm so sorry I had to take time off. It's an absolute necessity that I have to do this, and you guys know the things that I get myself into, so you know it's important. Otherwise, I would not leave you for any reason whatsoever. So I will be available to talk to text. I've been texting you guys while I've been doing this whole video. I think in one of these slides, one of you guys FaceTimed me and I had to let you go, but then I got rid of the slide and I finished up what I was saying and I called you and we talked for like half an hour, right? So you know I'm there for you. I'm always going to be there for you, right? I'm that person. I'm that girl and I'm happy to do it and I'm not going to change my ways or my thought process today, 3 years from now, or 20 because I've been this way my entire life. It's not going to change, okay? So if you need me, don't think, oh my God, I don't want to annoy her. Guess what? I open myself up to all of you and give you my number so that I can be annoyed because I know what it's like to freak out and not have anybody to reassure me that it's going to be okay. And some of those days were days where it was a make or break moment for me, and I don't want to lose that with you guys. I don't want to be the reason that the ball was dropped. I can't stand that. I can't live with that. So don't make me that person, okay? I say it a million times, but there's always one of you that's like, oh, I didn't want to bother you. I didn't want to inconvenience you. That's why I say don't bother me from midnight until 4, unless one of the big things are happening, right? And then call me, but make sure it's one of the big 4, right? You're panicking, you're having bad thoughts, you got into an accident, or, you are in the hospital and have to let me know, right? Those are the big 4 in my opinion. Anything else, it could probably wait until, 5, 6 in the morning when I'm getting up and getting moving. But I'm there and I'm available 22 hours of the day, 20 hours a day, and most of the time 24. So utilize that resource. I'm here. If I don't know the answer, I will find the answer. I always know somebody. I'm really good about finding people who are just as resourceful or even better, and I beg and barter and trade with them for favors. It's what we do as nurses. It's what we do as teachers. I'm going on about this for 4 minutes because some of you guys still aren't coming to me if you need me. Always feel comfortable. Know that I'm just like you. I don't care what's next to my name. None of that crap matters. It only matters so that I can get right here and prove to you guys that I'm worth it because I've got accolade next to my name. Other than that, it's literally a piece of paper that I don't care about because that piece of paper isn't going to distinguish whether I'm a decent human being or not. That piece of paper just says I was smart enough to pass a bunch of tests. Every time you look at any person with those pieces of paper, I never want you to feel fear or intimidation because at the end of the day, they are just like you and I, and they are no different, and they should not be treated like gods or demigods or feared as such. Do you guys understand me? That is not the deal. That is not why we're on this earth. That is not why we're inhabiting this rock, okay? We're here to support each other, to lift each other up, to increase our vibration, to increase our light within ourselves, and realize what we're really meant here to do, okay? What we're really meant to be in this world. And I think you guys have a good idea, and that's why you're here, and I'm proud of it. So, do the recipe. Make me some good pie, right? Don't forget the salt. Don't forget the sugar. Don't forget the bits and bobs and the little nuggets we talk about in between. I will start doing these 9,000 slides and gritting my teeth all along the way, and I will get them done hopefully by Wednesday so I can go about my day and my mission, and we can be done with this, and I can get back home where I belong to you guys. All right, we'll see ya.